I am presenting history of a 74-year-old male who is in pen transport business, resident of Mysore, Bangalore, presented with chief complaints of yellowish discoloration of eyes and urine since 25 days and epigastric discomfort since 3 days. Patient was apparently asymptomatic 25 days back. Then his son noticed yellowish discoloration of his eyes. Later on, patient noticed yellowish discoloration of urine, which was insidious in onset, gradually progressive, associated with generalized itching all over the body, not associated with pain, abdomen, or fever with chills and rigors. He gives history of vague discomfort in upper abdomen, more so in epigastric region, increased with intake of diet, relieved by itself. He says there is feeling of fullness on intake of diet. No relation of this discomfort to nausea, vomiting, any intake of medicine, no positional variation or relation to respiration. No history of frequent belchings, abdominal distension, no history suggestive of vomiting, hematemesis. History of loss of appetite since onset of present problem. History of loss of weight 3 to 4 kg in 1 month. He was previously 82 kg, now 78 kgs. No history suggestive of disturbances in micturition except for change in color. History of passing pale colored sticky stools about twice a day. No history of passing black colored stool or blood in stool, any other altered bowel habits. There is no history of breathlessness, cough, hemoptysis, headache, seizures or dizziness. Past history, there is no comorbid illness, being diabetes, hypertension, bronchial asthma, IHD. No history of recurrent episodes of pain, abdomen, jaundice, fever, biliary surgery in past. History of excision of swelling in right arm is there. If that was papillary outgrowth as described by the patient in 2016, and he was told that it was a benign pathology. No history of typhoid or pox in past, and there is no history of any drug intake, blood transfusion or TET. Personal history, not a smoker, no history of consumption of alcohol, high risk behavior, takes vegetarian and non-vegetarian diet, sleep cycle is normal, history of loss of appetite and weight, bowel and bladder habits normal, family history, there is no history of liver disease, any other malignancies in any of family members. Summarize, 74-year-old male with painless progressive yellowish discoloration of eyes, urine for past 25 days, associated with generalized pleuritis and passage of pale colored stool, history of vague discomfort in upper abdomen, feeling of fullness with noticed loss of appetite and weight.
Okay, Rakesh. So, go to your first page.
Yes.
So, what's the importance of age? Can you tell me, like, in relation? Just we'll discuss in relation to the neoplasms. Okay. So, because stone disease can present anytime. Okay, but in relation to the neoplasms, what do you think is the age group for pancreas? What is the age group for cholangiocarcinomas? Age group for gallbladder and age group for liver?
So for pancreas, ma'am, the most common age group is 7th decade, and 90% patients present over the age of 55 year. And for cholangiocarcinoma also it is 6th to 7th decade. And gallbladder, like progressively it is going more towards the younger age group, being 4th to 5th decade. And liver is also common in 6th to 7th decade.
I think liver is little early. Okay.
Okay.
And amongst these cancers, which are common in males and which are common in females?
Pancreas is more common in males, and GB is more common in females.
Is it?
But depends on, like in some areas, northeast side, it is more common in females, and over Overall, we can say it is more common in males.
It's males only. Okay.
Yes.
So, yeah. Then?
And cholangiocarcinoma is almost equal in incidence, if I am not wrong. And HCC is in males.
Okay. So, any relation to the occupation?
Yes, ma'am. Occupation in CA pancreas, there can be chemical exposure to like DDT and benzenes, pesticides. These all can increase the risk of CA pancreas.
Okay.
And for GP, it is not like farmers. In farmers, there can be there can be more exposure to like that.
So generally, all these have got whatever you have told, but one is that angiosarcoma of liver के लिए क्या है? Exposure to
Thorotrust था ना, Thorotrust, contrast.
Vinyl chloride. Okay.
Okay.
Vinyl chloride, angiosarcoma, more common. Okay.
Yes.
So okay, fine. So from your history, now you know history of presenting illness, everything. Okay. Broadly, you know history. So where do you think it is obstructive jaundice or it's a medical jaundice?
So, ma'am, signs of liver failure are not as such in the complaints or in the like we ruled out in also negative history.
What is jaundice, Rakesh?
Jaundice is, ma'am, yellowish discoloration of sclera, mucous membrane or skin due to increased bilirubin in body.
What is difference between hyperbilirubinemia and hypercarotinemia? In carotinemia also you will get yellowish orange discoloration. So what is difference between two?
Carotinemia is due to high ingestion of some particular vegetables like the carrots and
No. What is the difference in presentation between the two? Carotinemia spares sclera. Okay.
Okay.
Whereas jaundice hyperbilirubinemia can involve sclera, skin mucous membrane. Okay.
Yes.
So, yeah. So, from your history, now see, what are the points in your history which say it's a surgical jaundice rather than a medical jaundice?
So, like signs of liver failure, sign or symptom of liver failure are not there, ma'am. So,
not necessary, no. What is icterus? Icterus is also one sign of liver cell failure.
It can be, ma'am. Then
it can be nice. वो है, okay.
It is painless, progressive, and no.
Painless, progressive. Okay, it is some related to neoplastic. But I'm asking you, what is it? Yes.
No history of any fever, no history of hemolytic blood transfusion, multiple. ये सब आएगा in
platelet slowdown, platelets.
Only 2 points in this history will point out whether they are obstructive jaundice or not.
Yes.
Okay, one is pruritus, one is steatosis. Okay.
Yes.
So rest all things can be इधर उधर भी हो सकते हैं. But if these two are there, then it is definitely surgical jaundice. Okay.
Yes.
So yeah. So can you tell me before we go, what are the causes of jaundice? And what are types of jaundice? I mean, levels of obstruction of jaundice.
So, causes of jaundice we can divide like intraluminal or intramural, mural and extramural.
Prehepatic, hepatic, and posthepatic. Congenital or medical and
yeah,
surgical.
all of you are correct. Okay. So he's telling based on the site of obstruction. One is like prehepatic, hepatic, and post-hepatic jaundice. Yes. Then what are at the site of surgical jaundice? So what are the causes? Rakesh is telling. Okay, Soumyata is telling. Like what etiology? So all this can be. So now you tell me what are like the causes of congenital, traumatic, inflammatory, and neoplastic.
Congenital, it can be metabolic regions like hemolytic anemia can present, and that Dubin-Johnson syndrome, Rotor syndrome, Crigler-Najjar, these syndromic
Okay.
presentations can be there.
Other than that, हमारा jaundice में means surgical aspects.
Biliary atresia,
Choledochocele.
Caroli disease.
Yeah, biliary atresia. Okay.
Abnormal pancreato-biliary malfunction.
Yes. Then choledochal cyst.
Choledochocele.
Okay.
Yes, ma'am.
So all APBDJ, it includes all those things. Okay.
Yes.
So what are traumatic?
Traumatic can be after ERCP attempt or
Post cholecystectomy.
Stricture, ma'am. Post-surgical stricture.
or post
Surgical stricture. With any leak. Okay. Some post-surgical. Okay. Post-surgical only it will be stricture formation mostly. Okay.
Yes.
So that is traumatic. Okay. What is inflammatory?
Inflammatory can be due to cholecystitis or due to some infections, parasitic infections, and
Hepatitis and hepatitis मत भूलना jaundice में.
hepatitis also.
Primary sclerosing cholangitis.
Yes, PSC can cause stricture, and then it can be. And
What is hemophilia?
hemophilia is presence of bile in blood.
Why occur?
Due to obstructive cause, the pressure increases, ma'am. So it leads to backflow of bile into blood.
So it occurs in every obstructive jaundice or any particular case?
Causes.
Especially in traumatic causes, ma'am.
What is triad of hemophilia?
Triad is jaundice and melena can be there.
One more. Biliary colic.
Biliary colic.
Yes.
What is Charcot triad?
Charcots pertaining to cholangitis, jaundice, intermittent fever,
And jaundice fever.
pain
Intermittent fever, jaundice, and
pain in right hypochondria.
okay. What is Reynolds Pentard?
Pentard is more towards septic shock, so mental confusion, and I think hypotension will be there.
No. Mental obtundation and shock. Okay.
With shock, ma'am.
Okay. Mental obtundation, shock.
Yes.
Okay. So, okay, fine. So now you tell me what will be the painful and painless causes of jaundice.
Painless are mostly ma'am, intramural or extramural causes likely, and painful are mostly due to stone disease or due to cholangitis.
No, you give me examples.
Painless examples are, ma'am, C. pancreas, periampullary, distal cholangio, and second part duodenum, and due to some lymphadenopathy causing compressive symptoms at the porta.
If you are given an option between CA head of pancreas and periampullary carcinoma, which can cause more pain and which is more painless?
Head of pancreas
Head of
will cause
pancreas
more
can
pain.
cause more pain, ma'am.
Head of pancreas causes, periampullary is more so painless.
Yes.
And apart from that, painless causes can be any obstructive causes like due to parasitic infestations. Okay.
Yes. Yes.
Hemophilia can be painless. Okay.
Yes.
And in painful conditions, you will have head of pancreas, cholangiocarcinomas, cholangitis, any causes of cholangitis, polydocholithiasis. Okay. All these are painful and painless causes of jaundice.
Yes.
Okay. So now, So why skin and mucous membrane only should present with yellowish discoloration? And what's the level of jaundice when it presents with how much is the level of direct bilirubin when it is in the eyes and sclera, when it is in the neck, when it is in the thorax and trunk, and when it is in the palms and feet?
For eyes, ma'am, it is more than 3 milligram per deciliter. And because
When will you appreciate jaundice?
Generally more than 2 to 3 milligram per
Yeah, 2. More than 2.
Yes.
Okay. So what is the level that you can see jaundice in eyes, and what is the level that you can see jaundice in the neck? What is the level at which you can see it in the trunk, and what is the level at which you can see in the palms and toes?
So, ma'am, in eyes it is more than 3 milligram per deciliter, and in palms I remember it is more than 15. So based on that, I think neck will be 5 and thorax are somewhere around 5 to 10.
Okay, good. But it's okay. 2, 6, 10, and 15. Okay. So that's how it is. And what is when it is high level of jaundice, it involves the palms and toes.
Oh, yes.
So what is the cause of itching, Rakesh, in jaundice? Okay, before that, just tell me the intrahepatic circulation.
The bile acids that are secreted, there is enterohepatic circulation. So the major like 90% of the secreted bile acids, bile salts will be reabsorbed through the portal.
No. Enterohepatic circulation start with where?
Enterohepatic, it will like
hemoglobin breakdown. Tell.
Okay. So hemoglobin breakdown, like there are 2 sources of formation of bilirubin. First is heme-related proteins, enzymes, and then hemoglobin from RBC. So after
Abhijit, mute yourself, no?
Sorry, ma'am.
No. You continue.
Then this heme will break down, and there will be that heme oxygenase enzyme will be there, which will convert it into biliverdin. Then biliverdin reductase will convert this into bilirubin, and this bilirubin will be transported from the reticuloendothelial system to the liver bound with albumin, where it will reach the sinusoids and will be taken up by will be transported to the hepatocytes, and in hepatocytes the bilirubin will be conjugated by the acid. And then this conjugated bilirubin through the bile ducts, it will be secreted to the intestine, into the intestine, where the bacteria of intestine acts on it, and it gets again reconjugated and converted into urobilinogen and stercobilinogen. So majority of it gets reabsorbed. Some part is left behind, which is the reason for the brownish yellow coloration of the stool. Then 90% of it gets reabsorbed from this portovenous circulation, again into the hepatocytes, and some amount of urobilinogen is left in the blood, which is responsible and secreted through the kidneys, which is responsible for yellow color of urine.
So why is stool pale yellow, pale colored, and why is the urine yellow color?
So in obstructive jaundice, ma'am, as the conjugated bilirubin will not reach into the intestine, so the stercobilinogen will be not formed there, and this results in the pale colored stool. And contrary, it will increase the level of amount of bilirubin in the blood.
Okay.
So this is
that is filtered through the kidneys.
Yes, ma'am.
Okay, it will be increasing the renal load.
Yes.
Yeah. So
this will make it high colored urine.
Yeah. So urine, it will appear in urine. So what is the maximum amount of that a bilirubin can raise to?
In body, ma'am.
Hmm.
I'm guessing, ma'am. I don't know exactly. I think 30.
No, guess.
30. No.
Anyone else?
45 to 60.
45. Maximum is 45. Okay. So 40 to 45. Maximum is 45. Okay. Beyond that, it cannot go. Okay.
1 gram of hemoglobin is how many gram of bilirubin?
So, 6 grams of hemoglobin breakdown will lead to 2 milligrams of bilirubin. Okay. So, any 6 grams of free hemoglobin in plasma increase the bilirubin by 2 mg. Okay.
Yes.
Yeah. So now your patient has got itching. Okay. That is pointing out towards
Obstructive
the
jaundice.
obstructive pathologies. So
Yes.
no history of fever and with chills and rigors. So that rules out cholangitis.
Cholangitis.
Okay.
Yes.
And what is this vague discomfort in abdomen? Why do you think it is there? What is the
Vague
reason?
Discomfort, ma'am. It can be due to 2 reasons at this stage. It can be like locally advanced case involving the nerves around the celiac trunk, celiac plexus, or it can be some indigestion problems due to the like less secretion or absent of secretion from the pancreas due to the obstructive jaundice. So maybe the pancreatic duct is also obstructed. So digestion problems are there, which are leading to dyspepsia and bloating and all this.
So, in other words, I'm asking you, what are the causes of pain? You told one is advanced disease.
Yes.
Okay, with infiltration of the nerves. Okay.
Yes, ma'am.
Next, what can else?
Next is
Don't
like
confine
exocrine
yourself to
insufficiency,
pancreas.
or can be there, ma'am.
Okay, dilatation of the duct. Okay, chronic pancreatitis itself can dilatation of duct can be there.
Yes.
Okay, stretching
Yes.
of if it is in liver, secondary to stretching of the capsule or anything. Or if it is, what else can be there?
Some primary can be stomach, which is causing the enlarged nodes, leading to
Okay,
obstructive.
not pressing on it. Okay, then
And
so generally early stages of neoplasm are painless to start with. Okay, but in advanced stages they will infiltrate the neurovascular bundle and then they'll cause pain. Okay, so then
Yes,
what else? What is the cause of passing? What is typical stool that is described in jaundice? And what is typical stool that may that is characterized that is characteristic of periampullary lesions?
so the typical stool will
Silvery
be
stool.
pale or black colored.
Vaccine and waning effect.
Silvery stool. Why silvery stool approach?
When black plus melanoma is like
Sorry, your voice is not clear.
नेटवर्क देख
Hello?
लो डॉक्टर राकेश शायद ब्रेक हो रहा है आपका
critical में
Okay, anyone
अभी
else?
आवाज आ रहा है मैम? Hello?
Due to mixture of blood.
अभी
Yeah,
आ रहा है?
someone who completed. Why is that silvery
Ma'am.
color stool in periampullary lesion?
Because of pale colored stool along with presence of blood in stool, the melena will, this mix of color will cause silvery stool, like melena plus pale stool.
No. Anyone else?
No.
Okay, why is there steatoria? What is steatoria?
foul
Uh,
smelling
Hello?
foul
Undigested
smelling
presence
stool.
of
Sound of bright salts.
and
Pale colored stool?
presence of fat in the
Pale colored stool which floats in pan and which cannot be easily flushed off. Okay, that is definition of steatoria. So why does it occur?
Due to exocrine insufficiency, ma'am, fat will be not digested in the food elements.
Okay.
So it will
So-
increase more fat content.
Yeah, that's true. Okay. Why is there silvery color stool? Now you tell.
Because of fat, ma'am. Fat in pale.
Yeah, fat is there is steatoria plus. Why is it specific to this periampullary or head of pancreatic lesions? They do bleed.
Yes, ma'am. So fat plus blood.
Hmm. Fat
So
plus
this
blood will
steatoria,
appear.
silvery.
Yeah. So there mixture of acolic stools, that is bile due to bile obstruction with melena. Okay. So that will give rise to silvery color stools. Okay. So then yeah, can you tell me few causes of prehepatic, hepatic, and hello?
Hepatic are, ma'am. Hepatic are like these all hepatitis, cirrhosis, these all, and pediatria, and pre-hepatic syndrome, and
Your voice is breaking.
Rakesh, your voice is.
and
I'm not able to hear anything.
okay. Is it clear now, ma'am? I'll try again. I'll connect it again. Is it audible now?
Yeah, it's audible, but it is breaking in between. Yeah.
Okay, ma'am.
Tell me, hepatic is due to hemolysis. Okay? Hepatic is what you
Yes,
have
ma'am.
told. Okay? Post-hepatic
Yes,
is our obstructive or surgical jaundice. Okay?
Yes. Yes,
Yeah.
ma'am.
Okay. So, what else we have discussed about? Pancreatitis also can cause jaundice. So now you tell me what are prodromal symptoms? And why? When do you ask for prodromal symptoms?
To rule out hepatitis.
Prodromal
Okay. What are
hepatitis to rule out
prodromal
hepatitis. Yes,
symptoms?
ma'am.
Fever,
Which hepatitis
weakness.
are you interested in here?
Because of hepatitis B and C as well, ma'am.
A is
Not A?
common, I think.
Blood
Not A?
fever. A is not that common, but can ask.
A is also common. Okay. So B and C.
Okay.
Correct? Okay. So
Yes.
so can you tell me a word about how they cause jaundice, like in B, in C, and A? Just a word. Your voice is breaking, Rakesh.
Cirrhosis.
Hello?
Hello?
Hello. So there is something called direct damage, indirect damage.
In hepatitis, ma'am, there will be direct damage.
There is also indirect damage. Depends on which hepatitis.
Hepatitis B have, ma'am, direct like involvement of the DNA, integration of the DNA and mutation, ma'am. And chronic
Okay.
inflammation B and C.
Yeah, chronic inflammation will lead to cirrhosis, thereby dysplastic changes, leading finally to cancer. Okay. Then hepatitis A is through fecal-oral route. Okay. The same changes can occur, but it is through fecal-oral transmission. Okay. Then what? Yeah. So how is it related to diet?
How it's
Diet.
Diet.
Diet, ma'am.
Pain abdomen related to diet. So which diet are we referring to?
Pain
High
abdomen.
fatty diet.
Oily food, ma'am.
Pain
Yeah,
Spicy
oily
food.
and high fatty
Oily
diet,
food.
especially fatty diet. Okay, so they'll not be
Okay.
able to digest it because of the lack of the enzymes. Okay, so
Okay.
what is cause of nausea or vomiting in pancreatic neoplasms?
Neoplasia and vomiting can be due to bloating and all, ma'am. Dysphagia, indigestion, and then it can also be due to malignancy-related cytokines.
Your
Vasovagal
voice is not
symptom,
clear.
ma'am. Vasovagal symptom.
अभी क्लियर नहीं है.
मुझे ना आप
Rakesh,
अपनी वाइफ की फोन से
do
कनेक्ट
one
करो.
thing. Rakesh, you disconnect the call and then join again. Okay.
Okay.
Yeah,
Someone else can scroll the slides. Okay.
Okay.
So others, can any drugs cause cholestasis?
Drugs.
Penicillin, aminoglycoside,
Isoniazid, ma'am.
Sulfonylureas.
Sulfonylurea, correct.
Methyl dopa.
Anti-tubercular
Okay.
rifampicin.
Yes. And
And
antifungals also. Okay. So yeah, these are the most common cause of drugs causing jaundice. Okay, alcohol can cause jaundice, right? So how does alcohol cause jaundice?
drugs, alcohol. Acetaldehyde cause
So-
liver injury. Liver injury. It's not able to do conjugation of bilirubin.
It causes what injury? Most often?
hepatotoxin.
वो तो है उसमें
Is it hepatocyte?
टाइप 1 टाइप 2 रहता है ना. हाँ एक हेपेटिक लेवल मैम.
At the hepatocyte level. Okay. So yeah. So next is what? Rakesh, join back.
Yes, ma'am.
उसके
Yeah.
आवाज
So yeah, Rakesh. So next, what was your where is that presentation here? Anyone is sharing?
Not. I think
Is
this is
anyone
bigger
sharing?
in size, so this is good.
Can anyone else share the presentation?
2 minutes ma'am.
I have shared, but it is not visible.
Yeah, it is visible. I was just thinking that your network will be little better if you don't share the presentation. Okay, fine. So yeah. So what is the cause of hematemesis?
Hepatitis can be first due to the portal hypertension related varices are there.
Okay.
Second, it can do some gastric growth.
डॉक्टर
also.
राकेश
But it
आप वो
happens
कर लो,
not-
स्टॉप शेयरिंग कर लो.
To ask about nausea vomiting, ma'am. Well, it is because of only the delayed presentation of gastric outlet obstruction or something like that. Any specific cause other than this, ma'am?
So in cases of jaundice also there can be gastric outlet obstruction. Generally, when there is this obstructive jaundice, secondary to neoplastic etiology, it is the same. The release of cytokines, okay, which will stimulate the emetic
Yes, ma'am.
okay. So yeah. Yeah. So loss of appetite and loss of weight we discussed. So I'm not going again into that. Okay. So anything pale colored stools we discuss next.
Slide change.
So all these are metastatic symptoms. What are you interested in past history, Rakesh?
In past history, ma'am, diabetes, mellitus, hypertension are important as risk factors also in such cases. And then other conditions can also contribute to performance status of patient and our further plan. And then past history of surgery
Any
pertaining to
surgical intervention.
Yes,
Okay,
ma'am.
any
So
history
the
of
last
previous pain abdomen?
biliary, yes, ma'am.
Yeah, any pain abdomen, any intervention for calculate? Okay. Any previous history of taking any antiviral drugs? Any blood transfusions? Okay.
Yes.
Tattooing. Tattooing can cause what kind of virus? I mean viral. This one. Hello.
DNC.
Hello.
Hello. Well, ma'am. Hello.
Tattooing
कुछ
cause
problem है
what
तो
type
जरा
of
Lot of
jaundice?
disturbance here.
Not audible.
Come closer to mic.
You're audible, but your voice is breaking lot. Okay, fine. So, yeah. So, what is the cause of pruritus in jaundice?
Pruritus is because of the subdermal deposition of the bile salts leading to irritation of the nerve endings.
What are bile salts?
Bile salts are deoxycholic acid, lithocholic acid, like primary bile salts and secondary.
They're bile
are
acid.
cholic and deoxycholic. Yes,
They're bile acid. What are bile salts?
Oh, I think bile acids. I think these are bile salts.
Sodium chlorocholate, sodium glycocolate. Okay. So, are they bile acids which are implicated in etiopathogenesis of pruritus, or are they bile salts?
Bile salts.
Yeah, bile salts. What do they do?
Irritation of the nerve endings in subdermis.
Yes, hair follicles. So nerve ending irritation. So they will stimulate what?
Opioid receptor, ma'am.
Now next question also I'll ask that is related to your answer. Okay. What they'll do?
They irritate peripheral nerve.
Nerve ending irritation. Correct. What will they release?
They cause mass
Histamine, ma'am.
serotonin, histamine and serotonin.
Yes,
Prostaglandin,
mast cells will
interleukin,
release
histamine.
histamine.
Yeah.
Okay. Then
Okay.
there will be circulating pruritogens that such as lipophilic acid. Okay, which will lead to itching. Okay. Now, what is the treatment for this itching? Generalized pruritus in jaundice.
We then will give and epileptics as well.
Sorry,
Cholestyramine.
cholestyramine.
Cetirizine, and ambulatics.
So that's
Like
that's why I asked. Okay, does cetirizine relieve the pruritus?
No.
It causes sedation more, so kind of.
No.
Also
Cetirizine doesn't.
Yes.
So antihistaminics will not work. Okay.
Yes.
So you have to give this cholestyramine, cholestyramine, anti-opioid drugs. These pruritus, which is due to jaundice, is resistant to antihistaminics. Okay. So anti-opioid drugs can be tried because endogenous opioid release also will stimulate the pruritic cycle. Okay. So that's why you will give anti-opioids like naloxone, cholestyramine, cholestyramine, bile salts binding resins, okay, like ursodeoxycholic acid, deoxycholic acid. You can try with rifampicin, okay.
And these
Cetirizine.
SSRIs, sertraline and
Yeah, sertralins, okay. But you only one basic thing you have to remember is that antihistaminics will not work, okay. Right. So, abdominal distension can be due to malignancy causing GO or due to stones leading to some obstruction. Okay. So, next. So, why is there melena?
Melena is generally seen in periampillary.
Generally in the tumors which we are talking about now. Okay, which is more periampillary, correct. Okay. So,
yes.
Yeah. And we discussed about prodromal will be fever, arthralgia, malaise, skin rashes. Okay. And which state of hepatitis mimics cholestatic phase?
And that I'm not aware, ma'am.
Anyone else? Hepatocellular jaundice में this
Cholestatic.
obstructive, yeah. It is cholestatic phase which will mimic this obstructive jaundice. Okay. So why? Because there will be biliary fibrosis and some autoimmune changes or alcoholic induced injury also will lead to cholestasis. Okay. So drug, what all you told? One is one.
राकेश
She
आप
told
प्रेजेंट
me
कर रहे हो क्या?
that-
मैं अपना स्टॉप करूं क्या?
क्या?
राकेश इज प्रेजेंटिंग करके मुझे आ रहा है व्हेन आई एम शेयरिंग.
नहीं, मैं तो नहीं कर रहा इधर से.
स्टॉप शेयरिंग कर.
So in drugs, sulfonylureas can cause. Okay. Antibiotics. Any antibiotic? Anyone can tell what antibiotic is more notorious for causing jaundice?
Penicillin is there, madam.
कर सकते हैं क्या Pibzo?
Augmentin, amoxiclavulinic acid is more notorious. Okay. Then antivirals, zidovudin. Okay. Antitubercular, somebody told, rifampicin, pyrazinamide, INH.
Isoniazid.
Yeah, isoniazid, pyrazinamide, and rifampicin. Antifungal like ketoconazole. Any anti-epileptics?
Methyl dopamine.
कैप्टोप्रिल
Phenytoin.
Phenytoin.
Phenytoin. Okay.
Phenytoin.
Analgesics? Any analgesics you know that they cause jaundice?
Ibuprofen, paracetamol also can cause.
Our day-to-day paracetamol will cause. Okay. NSAIDs,
Yes.
basically. Yeah. So, what is cause of fever in jaundice? Rakesh?
Fever with jaundice can be due to the inflammatory causes, the infective causes.
Okay. What cholangitis?
Cholangitis, hepatitis, and like infection of.
Can malignancy present with fever? Among what we are discussing, any malignancy among this hepatobiliary tract can present with fever?
Malignancy with fever.
Cholangitis can present with fever.
Added infection is there, then can distal cholangio if there is
No,
infection.
without cholangitis, any malignancy can present with fever itself.
Hepatocellular carcinoma.
Yes, hepatocellular carcinoma will present with fever. Okay.
Paraneoplastic.
So, yeah, paraneoplastic syndromes. Okay. Other than that, metastatic symptoms you will ask for. Okay. So, in previous, you should also ask for any bleeding manifestations. Okay. So, any bleeding from gums or epistaxis. Okay. In previous, present only. Okay. Then, can you tell me why is the bleeding due to?
Bleeding can be due to hypersplenism.
Bleeding
that-
due to
Platelets and
You are telling portal hypertension bleeding. I am not asking that. In
Yes.
jaundice, there will be disturbances in
vitamin K related.
proliferation of that mass itself break off when there is a less blood
okay,
supply.
that can cause bleeding. I am asking per se in obstructive jaundice, there might be coagulopathy.
Coagulopathy.
So
Yes.
why is coagulopathy there?
So that vitamin K related
ADEK or
Also, fat soluble vitamin.
What happens to them?
their absorption will be
What is fat soluble vitamins?
ADEK. ma'am.
Okay, what happens to them in jaundice?
And it is obstructive jaundice, so their absorption will be hampered from.
So
the
their
bile
release
salts.
they're not released because gamma carboxylation is absent. Okay. So yeah. Then so IV drug abuse can cause, tattooing can cause. Diabetes, how you told me diabetes I'm interested in. Why?
Diabetes, it acts both as a risk factor also, and it can be a presentation of the carcinoma pancreas also.
So, what history you'll ask for a pancreatic cancer?
Recent onset diabetes.
Yeah, recent onset diabetes. Okay.
Yes.
So, then what long-standing diabetes can be there in?
Long-standing can be a cause of a risk factor for
It might be due to chronic pancreatitis itself.
chronic
Okay.
diabetes. Yes. Yes.
Yeah. So previous surgeries we have discussed cholecystectomy. Okay. Any CBD surgery or any slipped stone. Okay. Okay. Can you tell me what is primary and secondary stone in gallbladder versus hepatobiliary tract versus urinary bladder?
Primary biliary stones formed in the CBD itself. Secondary
Okay. What are secondary stones then?
slipped from from gallbladder. Like
Yes. And what about urinary bladder?
it is opposite.
We already discussed.
No. It is opposite in urinary bladder.
Yeah. Which are slipped from ureter are primary, secondary are formed in bladder. Okay. What is retained stone and what is residual stone?
Less than 2 years it is residual, more than 2 retained.
Retained stone and recurrent stone.
Recurrent, yes. More than 2 recurrent and less than 2 is retained.
Yeah. So, you already told Charcot's triad. What are exceptions? What is Kurzweil's law?
Kurzweil's law is if there is some extraluminal cause of obstructive jaundice is there, the gallbladder will be palpable. Or in other words,
Define Kurzweil's law.
When you palpate a gallbladder in obstructive jaundice,
gallbladder is not palpable in the intraluminal infective causes of
Anyone tell proper definition of it?
when gallbladder is palpable in obstructive jaundice, then it's less likely to a gallbladder origin.
You are explaining.
In a jaundiced patient with a palpable lump, it is seldom due to stone.
In a patient with jaundice,
With a palpable lump in right hypochondrium, it is seldom due to stones or palpable gallbladder.
If gallbladder is in a patient with obstructive jaundice, if gallbladder is palpable, it is seldom due to stones. Okay,
It is seldom due to stone.
Yeah. So what is it? Exceptions to Kurzweil's law?
Double stone, ma'am.
double infection, like
Double means where?
Either cystic duct and the common hepatic duct.
CBD.
cystic duct and
Bile
lower
duct,
CBD.
CBD and cystic duct.
Infected stone at the cystic duct का neck, gallbladder neck, sorry.
मैं ऑलरेडी
And,
बता चुकी थी
parasite.
मैम लास्ट टाइम, बताऊँ क्या?
हाँ बताओ.
Double duct stone, pancreatic calculus, obstructing ampulla, oriental cholangiohepatitis, and mucocele, and neck का gallbladder was that obstructing CBD.
And
Parasites.
that is oriental cholangiohepatitis.
Yeah, yes.
Absent gallbladder. Okay, post surgery. Okay, that is also one exception. Okay. So
Ampullary, ampullary is not there, na?
sorry.
That ma'am told is impacted stone ampulla, so it will lead to or not lead.
No, there is impacted stone, double impaction. Cystic duct, CBD.
Yeah.
Okay.
Yeah.
Pancreatic duct stone. Okay.
Yes.
Neck of gallbladder impaction. Okay.
Yes.
Oriental cholangiohepatitis, mucocele of gallbladder, and
Yes.
in absent gallbladder post surgery. Okay. These are exceptions to Kurzweil's law. Okay, next. Next slide, please. What are you interested in personal history?
Personal history, ma'am, smoking status, alcohol intake is there or not, and personal BMI will come in examination, though I will not see here.
Anything else?
Alcohol.
Any substance abuse? What about sleep? Very important in jaundice.
Sleep will be disturbed. Yes.
Not in all cases, but if
Can
sleep
be
is
due to
disturbed,
pruritus.
what is it due to?
Pruritus or pain. Mostly due to pruritus.
No. Sleep phase cycle is disturbed. What is it due to in jaundice, especially in patient with jaundice? Anyone?
Metabolic encephalopathy.
You are right.
Liver
but
failure का
Yeah.
symptom है.
Hepatic encephalopathy.
Hepatic
Okay.
encephalopathy. Yes.
Yeah. There might be difficulty in breathing, pulmonary. Okay. Hepatic pulmonary syndrome, hepatopulmonary syndromes. Okay. So, yeah. So, what do you look for that in hepatic encephalopathy if you want to rule out? One single investigation which might point out?
Ammonia.
Ammonia.
Yeah, ammonia. Okay. So, you should ask for any substance abuse, what is the type of diet they take, all this in personal history. Done. Next. Next. Yeah, family. What are you interested in family history?
Family history, ma'am, there are some syndromes and presentations associated with more risk of CA pancreas, like hereditary pancreatitis, HNPCC, and hereditary breast ovarian cancer syndrome, then ataxia telangiectasia, Peutz-Jeghers, all these, and familial atypical multiple mole melanoma syndrome.
Among all this, which has the highest risk?
Hereditary pancreatitis.
Are you sure?
And BRCA2 is the genetic.
Peutz-Jeghers, ma'am.
Peutz-Jeghers. Okay, 300 times risk it will be. Okay. So,
Two
yeah.
tables are
Second.
there and they always confuse. There, one says this Peutz-Jeghers, one says hereditary pancreatitis. वो hereditary.
No. Peutz-Jeghers has highest risk. Okay. So, yeah. Then, can you, okay, Rakesh, now I think the history is over, no? So, just to tell, can you tell me, though it is very crude, but what will be the color of jaundice in pre-hepatic? What will be the color of jaundice in hepatic? And what will be the color of jaundice in obstructive? It's very not followed, but just to guide. Previously, they used to take like that
Okay, ma'am. So
in pre-imaging era.
in post-hepatic, I think, ma'am, bilirubin is more towards greenish color, so maybe it is lemon green like something.
Yeah,
Light
greenish
yellow,
color.
golden and green. Light yellow in pre-hepatic, yellow in hepatic, and greenish yellow in post-hepatic.
In hepatic, it will be more of orangish tint,
Orange.
whereas in obstructive, it will be greenish tint. Pre-hepatic, it will be yellow, mild yellow. Okay. Yeah. So then, why is it like you will appreciate jaundice in the sclera?
Because jaundice gets bound to elastin, ma'am. So it is
Yeah, elastin has affinity towards bilirubin. Okay.
bilirubin. Yes, ma'am.
Yeah. So where else you can find jaundice? Where else you look for jaundice in general examination?
So conjunctiva, and then this our ventral surface of tongue, palate, skin, nails.
Okay. Okay, fine.
Mucosal
So, yeah, mucosal. Okay. So, what is the normal bilirubin level?
Normal should be less than 1 milligram per deciliter.
0.2 to 0.8. Okay.
Yes, ma'am.
0.8 to 2. Then subclinical jaundice. Okay. Above 2, it is clinical. Okay.
Yes.
Then, okay. First, let us discuss what are your differential diagnosis from your history, Rakesh?
So, ma'am, it is a 74-year-old male, painless progressive jaundice is there. And generalized pruritus is there, pale colored stool is there. So, more towards some surgical cause as presenting as obstructive jaundice. So, as there is no waxing waning, so I will go more towards pancreatic origin, then followed by periamp CA.
No, when you are asked a differential diagnosis, you tell diagnosis. Okay.
Head of
No
pancreas.
explanation.
Okay, ma'am.
Number 1, differential diagnosis.
Head of pancreas, ma'am.
Obstructive jaundice, secondary to, tell like that. Okay.
Obstructive jaundice due to mass in the head of pancreas. Yeah, malignant lesion in the head of pancreas.
Obstructive jaundice due to a lesion in the head of pancreas, most likely due to malignancy. Okay.
Second, it can be obstructive jaundice due to periampullary malignant lesion.
Okay. Accepted. Next.
Third, it can be some like distal cholangiocarcinoma can be there, ma'am. Duodenal second part carcinoma can be there.
Okay.
But duodenal
CAGB
second
can also
part
be
will
a-
present.
CAGB will be in more incidents. Third will be CAGB. Fourth will be cholangiocarcinoma. Okay, these are the malignant causes. Can you think still it can be benign?
Stricture can be there if there is some history or like history of past surgery or intervention is there.
Okay. Okay, fine. You have a broad range of diagnosis. Okay, we'll sort it out with the examination. Go to examination. In your general examination, you tell me what you are interested in.
So I'm interested in performance status. Then patient is oriented or not.
Okay.
Then BMI.
Hmm.
Vitals.
Vitals में क्या है specifically? Go to next page, ma.
If there are some infective causes or like as we discussed, Raynaud pentad is there associated. Shock is there. We have to see the general condition and white patient is vitally stable or not. We have to resuscitate or not.
So you mean to say you are interested for looking at pulse rate?
And BP. Yes, ma'am. Pulse rate.
What happens to pulse rate?
Tachycardia can be there.
Bradycardia due to
Brady-
deposition of bilirubin.
Sinoatrial node deposition.
Bilirubin
Of what?
SA node.
Bilirubin
Correct.
deposition.
Okay.
Bile salt deposition. Okay. Sinoatrial node acts as a pacemaker, Rakesh. So, whenever there is bile salts deposition in a patient with obstructive jaundice, you will get relative bradycardia. Okay.
So we like my
Right.
cholangitis is more common, or we can spot this before that.
No, if they have more of infective cause, there can be, and in sepsis. Okay, so there can be tachycardia. But if you are asked why will there be bradycardia in a patient with jaundice, this is the reason. Okay.
Yes. Yes.
Need not be in all patients with jaundice you will get a bradycardia, or need not be in all patients of jaundice you will get a tachycardia. Okay, you should know the reason when they will be there. Okay.
Yes.
So tell me what happens to BP.
BP can be low, ma'am, if there is associated shock is there.
Okay.
Otherwise, patient can be, if patient is hypertensive, then also.
So it can be due to per se due to decreased cardiac contractility. Okay, that occurs in this patient. Okay, and there might be hypotension. Okay, there might be sepsis induced hypotension. Okay, so yeah, next page. Yeah, so always as a routine, never tell about pallor in jaundice patient. Okay, that's very important. Okay.
Yes.
So pallor could not be assessed. If a patient is jaundice, you cannot assess pallor. Okay, that is one thing you should all remember. Okay, as a routine, we'll just write no pallor like that. Okay, you shouldn't write. So ICTRES we already discussed where all we look for. Okay, then okay. Other than that, supraclavicular lymph nodes is for metastasis. Pedal edema might be secondary to what, Rakesh?
Pedal edema, first it can be, if it is some hepatic mass, then it can be due to IVC thrombosis or like that. Otherwise, it can be due to
Simple, Rakesh. Jaundice में nutrition कैसा होता है?
hypoproteinemia, and then
That's it. Simple.
Yes. Mm.
So, yeah, scratch marks we already discussed. Mostly you will see it over which aspect scratch marks?
Over like abdomen or flexor surface of upper arm.
Extremities or abdomen.
Abdomen.
Yeah. Next. Samyata, next page. Yeah, that's under surface of tongue. Okay. Yeah. Okay. What do you want to see in parabdominal examination?
Per abdomen, ma'am, we will see if there are any dilated veins or scar, if previous operative scar, then movement of quadrants with respect to, first we will see any fullness is there or not, then movement of the quadrants with respect to respiration, and then yellowish discoloration, scratch marks, all this.
Okay. And what are you interested to look at the umbilicus?
Dilated veins can be there in case of portal hypertension, caput we will rule out. Second, ascites can lead to everted or smiling face-like or slit-like umbilicus. It can change the configuration of umbilicus.
Okay.
And
So
then,
can you tell me any 3 causes which will lead to flank fullness?
flank fullness, ma'am, ascites can cause. Renal mass, in this case, or ma'am?
No, in general only I'm asking.
Renal mass
Then?
can cause. Renal mass.
Then?
And any ascending, descending colonic mass, retroperitoneal mass.
Pregnancy.
Splenic mass. Pregnancy, yeah.
Okay.
Yes.
So what are causes of distended abdomen? Can you tell me 5 Fs?
Distended abdomen can be due to obstruction, ascites,
5 Fs.
Feces,
Fat,
fluid, flatus,
Fat
Fluid fetus.
fat,
flatus
fluid,
also.
Fat, fluid, fetus, flatus.
Yes.
One more F.
fat, fluid.
Full bladder. Okay.
Yes,
Yeah. And feces. Okay.
yes, ma'am.
Then. Yeah. So what are the causes of upper abdominal fullness?
Upper abdominal can be due to gastric outlet obstruction or some large.
Gastric outlet obstruction, general it will be. Any distended gallbladder can cause?
Distended gallbladder can cause. Pseudopancreatic cyst, not that common, but if it is large enough in thin patient,
Yeah.
it can cause.
So any choledochal cysts, any tumors in upper abdomen can cause upper abdominal fullness. Okay. Then what is Meniere's syndrome, Rakesh?
Meniere's syndrome is infection of the stone in the GB neck, causing obstruction of the adjoining bile duct, CBD or CHB.
Okay. And one more thing that Courvoisier's law will not be applicable is intrahepatic gallbladder. Okay, absence of gallbladder or intrahepatic gallbladder. So these 2 things. Okay. So what is gallbladder point?
It is just below the costal cartilage in the midclavicular line.
More specific. Anyone?
Tip of 9th costal cartilage.
Correct.
Midclavicular
Right
line.
hypochondrium in the tip of the 9th costal cartilage. Okay. When you feel a globular smooth mass, separate from the liver and finger insinuated between costal margin and the mass, then it should be a gallbladder. Okay. So what are the causes of splenomegaly?
Splenomegaly with this can be due to
Yeah, with this.
portal
With this only.
portal
Yeah.
hypertension. Can,
So portal hypertension, splenic vein thrombosis, or portal vein thrombosis can lead to splenomegaly in jaundice. Okay.
yes.
What is cause of hepatomegaly in jaundice?
Hepatomegaly can be due to the intrahepatic cause first. Some intrahepatic causes causing jaundice. Hepatic mass can be there. Then due to
In a patient with obstructive jaundice. Okay.
Hydrohepatosis.
Hydrohepatosis. Okay. or any IHBRD. Okay, that leads to that is seen. Okay, so how do you percuss for liver span, Rakesh? We already discussed, but just revision.
So we will start from the fourth like intercostal space in the mid-clavicular line.
So some people say you should start from second intercostal space. Okay, so second intercostal space down way to
in the mid-clavicular line till the dull note is we hear the dull note on percussion.
Okay, what is normal liver span in mid-clavicular line?
It is around 10 to 12.
8 to 12. Oh.
8 to 12.
Yeah. So then, okay, what else you will look for hernial orifices sign? Yeah, that's it. Next. Okay, next. Yeah. So on palpation, there was a mass. Okay.
Yes, ma'am.
So most probably it is a gallbladder, right? We already discussed in last class, so I'm not stressing on it. Okay.
Yes, ma'am.
And next one. Yeah, this also we discussed liver span. What is venous hump?
Venous hum, ma'am, it is a vascular sound heard over the tumor or like due to increased vascularity.
There is one sign, no? What is that sign?
Sign I'm not recollecting.
Anyone else? What is the sign of venous hum being heard in a patient with jaundice and portal hypertension? Cruvel hair, Baumgarten sign. Okay.
Baumgarten.
So,
okay.
yeah,
Baumgarten
Yes.
syndrome.
Yes.
Cruvel hair, Baumgarten. Okay. So, what is the etiopathogenesis of left supraclavicular lymph node?
Left supraclavicular lymph node first due to the location of the thoracic duct in the nearby area. So the tumor emboli will traverse through the thoracic duct to the junction of IJV and left SCN. From there, once there is obstruction or complete occlusion of the thoracic duct, they will extravasate to form the deposits in the left supraclavicular region. Second,
so there will be reflux from at the junction of left thoracic duct and left IJV.
yes.
So this narrow tumor cells cannot pass through that. Okay, so they'll form as a swelling. Okay.
Yes.
So what is it? Is it Traugios or Trozius? What sign it is?
It is
Troisiers.
Troisiers.
Spell?
Troisier.
Yeah. What is Traugios?
Migratory
Now is
thrombophlebitis.
migratory thrombophlebitis, superficial migratory.
AU.
Yeah. In hypocalcemia, what is that?
Chostek and
वो ट्रूसो साइन होता है चॉस्टिक साइन भी होता है ना
Chopstick and Trousseau sign.
Prostate and prostate.
Yeah. The Chostek sign. Okay.
Yes.
So yeah. So now you tell me based on your PR findings are normal, I think. Okay, except for steatoria. Next page. Yeah. So based on your findings and history, now you tell me what it could be. Just come to one or two diagnoses. Okay.
Yes, ma'am. So as based on history, we concluded that it is obstructive jaundice, and on examination again the GB is palpable, so it is due to some extra luminal cause, and then there is fat content also confirmed on the PR examination. So for my first diagnosis will be obstructive jaundice due to lesion in head of pancreas, most probably malignant etiology.
Okay. Second.
Second can be
And don't tell the extrinsic cause of distended GB. Okay, you still don't know. Do intrinsic intraluminal causes do not cause a distended GB?
if exceptions are there, they can go.
So don't come to that conclusion. Okay.
Okay.
Yeah. Then
Periamp malignant lesion.
oh, right. So you think either it's in the pancreas whatsoever. Okay.
Yes.
Ma'am, why not periampullary as the first and head of pancreas as the second?
Waxing when
Yeah.
Vening nahi tha.
See, no. One thing is she's right
Because there is
because
no
the
clean
history is
abdomen.
too short. History is too short that you cannot tell there is no waxing and waning. Okay. It's
Okay.
only 25 days history, right? So still periampullary can be a possibility. Okay, but head of pancreas can be told, and you can tell still it can be a periampullary because of the short duration of the history. Okay,
And
I cannot comment on waxing and waning.
To say that in case of
Sorry,
most common, ma'am, can
Avneet,
we
your
state
Voice
this
is
as one of
not
the
clear,
reasons?
Avneet.
Ma'am, can we also state this reason that in case of obstructive jaundice, since pancreatic cancers are more common, so I leave that as a first. Can we say this one as one of the reasons?
Periampullary itself is covering the 4 groups actually.
okay, what is periampullary, Avneet?
Ma'am, distal CBT, ampulla of Vater, head of pancreas, and first part of duodenum.
Head of pancreas entire thing or anything specific definition is there?
2 centimeters.
periamp within 2 centimeters from the ampulla.
From the ampulla. Yes.
4 parts. Yeah.
So you are not wrong in telling either way. Okay, because of the short duration of history, even if you tell periampullary, nobody will object. Okay, but when it is from 6 months or so, then it is safe to tell head of pancreas first because there was no waxing and waning and it was a progressive jaundice. Okay.
Second, ma'am, incidence of head of pancreas is more common than periamp, I think.
Yeah, you can tell, but they'll not accept. Okay, generally. So even if you tell periampullary first and then head of pancreas, you're not wrong. Okay, nobody will see whatever it is differential diagnosis. Okay,
Yes.
so you'll always tell I will confirm my diagnosis through imaging. Okay, so don't worry about that order. Okay, either any of these two diagnoses are okay to tell. Okay, so gallbladder can be present, but it is rare. There is it's a painless jaundice, so right hypochondrium pain is not there, which is more a feature of VB mass, GPCA. Okay.
And jaundice, like in gallbladder jaundice to be present, mostly it will be due to lymph nodes and it will be advanced stage, so patient's GC will be down actually.
That's why you didn't tell, no? So only 2 diagnoses here at the end of your history and examination are accepted. Okay. So now how do you want to proceed?
So, as I am suspecting first diagnosis to be malignant lesion head of pancreas, so first I will get an USG abdomen in form of extension to my examination.
Again, I'm telling. I'll do my investigation. Yeah. As an extension of my clinical examination, I will do an ultrasound.
Yes.
Okay.
Yes.
To confirm my diagnosis, I will do an imaging. Okay.
Yes.
With some biomarker. Okay. And
Yes. Staging and then.
I will also do the staging simultaneously. Okay.
Yes.
And I'll do the routine test to plan the management. Okay.
Yes.
So tell. Now what first ultrasound, right?
Yes, ma'am.
Yeah. Tell me.
Ma'am, should we say I like to do to confirm my diagnosis, I like to do a first LFT followed by sonography followed by whatever the finding I get, then CT abdomen or something like, because some examiners like LFT.
Tell me, Abhijit,
Yes, ma'am.
how will you confirm your diagnosis? LFT will tell you
Whether it
It's
is like
obstructive jaundice or not.
yes, ma'am. Yes, ma'am.
Oh.
It will give
So
the.
you already know it
And
is
liver
obstructive jaundice.
condition also, ma'am. Liver condition also it will give.
Hmm.
Yeah, it will give a clue to your diagnosis. It will
Okay,
give a
ma'am.
clue to your management.
Yes.
So
Yes, ma'am.
anything what you tell as confirmation of diagnosis should actually guide you where the origin of the lesion is. Okay. So
Okay, ma'am.
in pancreas, because we don't do a biopsy, it will be most likely imaging. Okay. Imaging is confirmatory in pancreas. Okay. Other things which will give a clue to your diagnosis will be CA99, LFT,
Yes, ma'am.
coagulopathy. This will help you to manage the patient. Okay.
Yes, yes, ma'am.
Okay.
But like we say, the imaging first, and I also like to do a LFT and some biomarker. We can add in the diagnosis itself because
You can add. See, that's why you tell it as a continuous sentence.
yes, ma'am.
As an extension of, if I am asked, I'll tell. As an extension of my clinical examination, I will like to do an ultrasound abdomen and pelvis to know the origin of the mass, as well as to know the more details. I would like to stage, and for staging, I would like to do a triple phase CECT with pancreatic protocol. And
Yes.
for the management of the patient, I would like to do the routine investigations. Okay?
Okay.
If you tell it like that, nobody will object. Okay? Yeah. So tell me now, what do you want to do in ultrasound? What do you want to see in ultrasound?
So ultrasound, ma'am, first it will tell us about the organ of origin and like imaging characteristics of the lesion, then extent of the lesion, and any presence or absence of regional nodes, ascites, distant mets to liver. We can see all these things.
थोड़ा ट्यूमर से बाहर निकल.
IHBR, liver status,
Yes.
The most important thing in ultrasound you forgot, IHBRD.
IHBR.
Okay,
Yes.
this will tell when it is obstructive jaundice. Okay, you will see the anatomy. Start like what you see, anatomy, site, whether there are any stones. Okay, how are the ducts? Whether you are seeing any lymph nodes. Okay,
Yes.
whether you are seeing any free fluid.
Yes.
You are seeing any thrombus. You are seeing any splenomegaly. Okay, all this can be seen in ultrasound. Okay, which will actually give you a whether it is a localized disease or advanced disease. Okay.
Yes.
Then, what do you want to actually confirm your diagnosis with?
Then I will, if it is pancreatic mass, I will get done CCT with pancreatic protocol.
What is pancreatic protocol? And do you call it a CCT or you want to add some adjective to it?
Then I'm confused between triphagic and dual phase. Like I used to tell it triphagic then, but
Pancreatic protocol.
in pancreatic protocol I told already. So I'll say triphagic CCT abdomen and pelvis.
Okay, what is normal CCT? What phases you see, Rakesh?
In normal.
Leave all alone. Things like abdomen you are doing. So what phases you see?
Non-contrast and arterial.
You will see a plain CT. Then
And
you will see a
Arterial.
arterial phase. Okay.
Yes.
So why is this called triphasic? Why are you interested in triphasic in a hepatobiliary pathology?
Because it tells us about first it will be non-contrast, then early arterial or we can say parenchymal phase, and then delayed portovenous phase. So that arterial phase will tell us about the arterial anatomy, any aberrant or replaced arterial.
So first is plain CT. What does plain CT tell you?
Plain CT can tell us about if there is any stent or not. Like first, it can tell us about the mass little bit, but not in detail. Then stent or stone, presence or absence of stone, it can tell us.
So it will tell about the localization of the gland as well as any calcifications. Okay, you will see better calcifications better on a plain CT. Okay.
Yes.
So what is negative contrast?
Negative contrast is like water or mannitol. They can be used negative contrast.
Okay. What is contrast?
Contrast is something which gives
Positive.
the interface to compare with
No,
the
no. What is positive contrast? I'm sorry. What is positive contrast?
positive is
Here.
non-ionic iodinated or ionic iodinated contrast agents.
Okay.
Ma'am, is
So
gastrographin also considered as a positive contrast?
Gastrograph can be positive.
gastrographin you will give no.
Can be.
When you don't give anything, you consider bile or water or mannitol. Like you just see through the movement. So that is called negative contrast. Whereas when you give something, that is a positive. Gastrographin is a positive contrast study. Okay. So what contrast you will use here?
We can
Negative
generally what
contrast,
will be
ma'am.
negative contrast.
Okay. If you use a IV contrast, what is the contrast? And how much will you give? How you will inject?
Non-ionic iodinated contrast 3 to 5 ml per kg IV
3 to 5 ml per
kg body weight.
3.
3 to 5 ml per second. Okay.
Okay, per second.
And how much will give? You will give around 100 to 150. Okay.
Yes, ma'am.
Yeah. So what do you want to say? I mean, when do you want to see what phase, and what are you interested in seeing in that phase? Tell me everything.
In non-contrast stage, we will see the gland status and then any calcification. Then in arterial phase, we will see.
So you told me something pancreatic protocol. So what is it?
Pancreatic protocol is first is triphagic, then thin slice, preferably 0.5 to 1 mm. But
is there any? Yeah. So now you have come. So triple phase is to look at all this portal phase, arterial and venous phases. Okay.
Yes.
Whereas pancreatic protocol tells about the cuts. Okay. So how much cuts it will be?
1 mm.
0.5 to 1 mm and preferably less than 3 it should be.
Yes. So now what do you want to see? Which phase, what will be seen? You tell me now.
So non-contrast.
And how many seconds?
Yes, ma'am. Non-contrast as we discussed, ma'am, then arterial around it will be 25 to 40 seconds. It will tell us about the state of arterial system, vascular anatomy, any anomalies there or not. Then the parenchymal phase also. It will tell us about the uptake by the tumor in contrast with respect to the parenchyma of the pancreas. And third is that delayed portovenous phase, which will tell us about washout or any changes related with that, or liver lesions. If there are some liver lesions, we can better appreciate them in this delayed portovenous phase.
So portovenous phase at what time you will take?
Around 60 seconds, ma'am. 60 to 70.
60 to 90 seconds. Yeah. And pancreatic parenchymal phase?
Around 40 to 50 seconds.
30 to 40 seconds is for 30 to 40 seconds is for delayed arterial phase, yes, which is pancreatic parenchymal phase.
Yes.
What should be the interslice gap?
0.5 to 1 mm.
No, you're telling the cuts. I'm telling interslice gap. Ideally, it should be 0. Okay? 0. Because when you want to see the arterial venous reconstruction, no, so you should not have any interslice gap. Okay? Yeah. So, okay. In relation to this, I'll just ask you, what is Henle's trunk?
Henle's trunk?
Not renal. Not asking Henle's loop. I'm asking Henle's trunk.
Henle's trunk,
branch from gastroduodenum.
Epiploic and middle colic artery junction.
3 junction, ma'am.
3 are there, no?
3, right, gastroepiploic, right, renal, right, middle colic, ma'am.
Middle or right?
Middle. Right, gastroepiploic.
Right.
Gastrocolic trunk only.
Right colic and this.
Hey, one of you tell, Ray. Everybody is shouting, I'm not able to. One of you tell.
Ma'am, right gastroepiploic, right colic, and inferior pancreaticoduodenal.
right colic, right gastroepiploic, anterior superior pancreaticoduodenal. Okay.
Okay.
So there will be many like variations in Henle's trunk. How many variations are there?
Exact variations I'm not remembering.
Anyone else? How many variations are there?
5, madam.
6 variations. Six variations will be there. Okay. So 6 will be apart from described. If anything is there, it is 6. Okay. Generally, people will think it is 5, but 6 are there. Okay. So
Loop
either
of Henle or Henle trunk? What should I remembered it like loop of Henle?
no loop of Henle. It is Henle's trunk. Loop of Henle is in kidney. Okay. Nephrons. Henle's trunk it is called. Okay. So type 1 will be most common. Okay. Which will be like right gastroepiploic, anterior superior pancreaticoduodenal, and right colic vein arising from a common trunk. Okay. So next will be like 1 will be absent, 2 will be arising from the same, or 3 will be from different. Okay. All this will be variations. Okay. Just go through that Henle's trunk once. Okay. When you have time. So yeah. Then what was anything else? What investigations you want to do? Ultrasound you told. Anything in coordination with ultrasound? Anything else you can do? Especially for pancreatic EUS.
Elastography.
Elastography less, but EUS. I wanted to ask EUS. Yeah, EUS. What is the use of EUS?
EUS we can use for smaller lesions, say smaller lesions in endopancreas less than 2 centimeter, or if we are planning some pre-op or planning some biopsy to rule out our differentials or
FNAC of some lymph nodes, or as a palliative measure for celiac plexus neurolysis. So these are the 3 things of EUS. It has increased sensitivity.
Yes.
So what else you want to do? Imaging. Will it suffice? So triple phase CCT is good enough.
Yes.
So suppose you are suspecting some anatomical variation. So what do you want to do?
Anatomical variations in arterial system, ma'am.
Angiography.
I think ma'am CT is good enough, but then we can do angiography, CT or CT angio or MR angio.
Can you do MRCP?
MRCP for bile duct status with MR angio. If we have some confusion in cholangio regarding bile duct infiltration.
Yeah, it defines the anatomy better. Okay.
Yes. Yes.
So and what ERCP?
ERCP if we are planning stenting. And together.
Stentotomy and stenting. It is both diagnostic and therapeutic.
Yes, ma'am.
So now you tell me what kind of stent you want to put. Patient is operable. But you want to now, you can go to the investigations of this patient so that we can discuss.
Blood investigation.
So what are your routine?
CA99, we are not discussed.
Yeah, I'm coming to blood that's why I told him to project that investigations. Okay. So don't see this investigations, Rakesh. Okay. So what blood investigations you want to do?
Blood investigations.
So you want to do routine investigations only. What routine investigations?
Routine with tumor.
Routine what? Yeah, CBC. Why you want to see CBC?
Sorry, ma'am.
Why do you want to see CBC in a jaundice patient with CA pancreas? What is your idea and what you will derive from getting a CBC done?
For our plan, management plan, ma'am.
Accepted the routine investigation.
For our plan, management plan, ma'am.
Okay. So you are interested to see whether the patient has anemia or not. Okay. It's a bleeding tumor or not. Okay. Second thing, you will be interested to see total count. Okay, where the patient is having infection. You have to start him on any antibiotic or not. Okay. Then you will see for any coagulopathy, that is platelets. Okay. And as well as what is, if you are asked, one most sensitive investigation of LFT to define
INR.
obstructive jaundice?
INR.
No.
ALP.
First investigation that gets deranged in a obstructive jaundice coagulopathy.
ALP.
Sorry?
ALP.
Alkaline phosphatase.
It's prothrombin
Alkaline
type.
phosphatase.
It's prothrombin type. Okay?
Okay.
Yeah.
Okay.
So, and what tells difference between whether it's obstructive pattern or a like medical jaundice is total bilirubin to direct bilirubin.
Yes.
Okay? So
Yes.
what should be the difference? Normal?
Obstructive jaundice direct will be.
It will be more. Indirect will be less. Indirect will be more in hemolytic, the medical jaundice. So, but what will be the difference?
Difference in what symptoms?
Difference between direct and indirect bilirubin, roughly.
3 times. 3 times.
Anyone?
4 times.
So its difference will be around 4 to 4.5. Okay. So Soumyata is dancing there. Okay. Yeah. So what do AST, SGOT, SGPT tell you?
They tell us about that hepatocyte hepatocellular. My voice is again clear.
वॉइस इको
Yeah,
हो रहा है, मुझे लगा कि मेरे से हो रहा है इसलिए मैं म्यूट किया.
Okay. You tell Rakesh now.
We can see the function of the like if it is any or due to cholestasis,
So where do this SGOT, SGPT rise more? In hepatocellular.
Viral
Hepatocellular and viral hepatitis causes. Okay. What are the enzymes which rise in obstructive jaundice?
alkaline phosphatase.
Now you tell heat stable, heat labile.
Table.
Everyone mute please.
Heat stable, correct. In liver.
Yes.
Heat labile in bone. Okay. Then yeah. So renal function test to rule out any hepatorenal issues. Okay.
Yes.
Then
Imaging.
yeah, INR you will see coagulopathy. And you'll see the electrolytes. And above all, serology, very important. Okay. In any jaundice case,
Yes.
serology is important. Then next, CA9. Yeah. Next. Next, Soumyata. Tell me something about CA19-9.
So CA19-9.
What is CA19-9? What is CA?
Carbohydrate and antigen. It is carbohydrate and antigen. My voice is echoing.
correct. Yeah. Okay, others can tell. Someone else take the lead.
ma'am.
Yeah,
It is
tell me
a
something about CA19.
short chain amino acid. Carbohydrate antigen.
Is it amino acid?
नहीं
Protein, ma'am.
No, ma'am. It is glycolipid, ma'am.
Glycoprotein. Protein or
What is CA19? You told carbohydrate antigen.
antigen? I think
So what is it?
antigen. I think it is protein.
Antigen
glycopeptide.
तो it's a glycopeptide.
Yeah. So what is importance of CA19 and what is the normal value?
Normal value should be less than
Sorry?
less than 35 units per
Okay.
and
So when it is called significantly raised, and when is it called when it has poor prognosis?
if it is in thousands,
डॉक्टर राकेश आप एक बार लॉग आउट होके लॉग ऑन
मैंने दोबारा कर लिया someone else I think दो बार है क्या कोई लोग
नहीं आप ही का ही है और कोई म्यूट सभी अनम्यूट है
मैंने अभी डिस्कनेक्ट करके
I
दोबारा
think it's better now. It's better now, no problem. Okay. Yeah, what was I asking? CA99, when is it called significantly raised? And when it has poor prognosis?
more than 1,000
So it definitely will have metastasis. Okay. Then
yes
3 times its normal value, it is called more significantly raised. Anything above 200. Okay.
Yes.
So yeah. So
Yes.
now CA also can be raised. Okay. So
Yes.
pancreatic CS. Okay. Especially if there are some mucinous carcinomas or something like that, CA can be raised. Okay. Ultrasound abdomen pelvis we have discussed. Okay. So what is the normal CBD diameter, Rakesh?
sorry ma'am
Normal CBD diameter.
diameter it depends like USG or
7 millimeter.
USG में 7 and
I'm asking in relation to USG only.
yes ma'am
So does it have any relation to age?
age
It does. Okay. So, yeah. So infants it will be 2 mm. Okay. In children it will be around 3 mm. Okay. In 4th decade it will be 4 mm. Okay. In 5th decade it will be 5 mm. Anything above 7 mm it is called dilated CBD. Okay.
yes ma'am
Okay. So what is this APBDJ? Somebody was telling APBDJ. No, what is that?
abnormal biliary duct junction
Abnormal pancreatic or biliary duct junction. What it means actually?
like it is not duct and bile
So what is this the ducts they are talking about?
common duct
Pancreatic and bile duct. Okay. Yeah. When they open in the duodenum, if the distance between them is more than 3 mm, okay, they are called abnormal pancreatic or biliary duct junction. Okay.
yes
Yeah. So yeah. Next, what I want to ask? Yeah, that is about LFT, RFT, CEA, tumor markers. Imaging mein we have come till MRCP. So what do you want to see in MRCP additional to CT?
MRCP carcinoma is there and we want to see
In MRCP.
carcinoma is there and we want to see the proximal
Not only cholangio, yeah. You see the vasculature well, okay? Even triple phase CCP is sometimes. Yeah, sometimes if you have some doubt, so it can always be confirmed through an MRCP. Okay.
Yes.
So tell me something about what is borderline resectable, what is resectable, and what is yeah, that's it. Borderline resectable and
so according to NCCN borderline
so it differs with the site of the lesion. Okay.
Yes, ma'am.
So
Yes.
for head of pancreas, what is it?
so for head of pancreas with respect to artery we can describe it if we see the celiac axis or SMA less than 1. My voice is
It's breaking.
echoing also.
Yeah.
What should I?
No issues. Okay. Talk. You stopped sharing, no? Still, it is. You have a bad internet connection, I feel. Okay. Okay, someone else can speak. What is borderline resectable? What is resectable?
The contact with the celiac axis and SMS should be less than 180 degree. And CHA if it is not extending to celiac axis. With respect to vein, either it should be it can be more than 180 without any irregularity or thrombosis or less than 180 degree with irregularity in the vein with resection and reconstruction.
There is a lot of echoing, Rakesh.
Yes, ma'am. When
Okay.
disconnect and connect.
No problem. What you have told, I have understood. Yeah, you can disconnect and connect. Yeah. Someone else repeat, please. With respect to artery, vein. What is resectable, borderline resectable, and advanced?
When there is less than 180 degree connection with arterial connection, then it is resectable. If there is more than 180 degree connection with the vein, but less than 180 degree with the CHA and SMA or hepatic artery, but it is reconstructible. This is borderline, but whenever there is more than 180 degree with artery, it is not resectable.
It is still echoing. I think we also disconnect and connect.
Uncinate process when it is in body and tail. Okay. Definitions of borderline resectability will refer. Okay.
Yes, ma'am.
Right. So, right. Then, can you tell me, like, there was one classification, no, with of arterial relationship with the tumor.
Arterial relationship with tumor. That
Yeah.
in respect to borderline resectable.
So, if it is no arterial, yeah, in respect to the resectability, not borderline exactly, but resectability. If tumor is not in contact with the artery, it is
resectable.
type A. Okay. Yeah. If it is in contact with the artery but less than 180 degrees, it is type B. If it is more than 180 degrees with border irregularities and with or without caliber irregularity of the vessel, it is type C. Okay.
Okay.
With respect to vein,
Ma'am, less than 180 degree, and
so A will be no venous contact. Okay. B will be venous contact less than 180 degrees without any stenosis of the vein.
yes,
Okay. C will be less than 180 degrees with the stenosis. Okay.
Okay.
And D will be teardrop sign. Okay. Which
What
you
is
see.
it called, ma'am? Any name or-
Teardrop sign.
This
Nothing
classification.
specific.
Okay.
No, this was given in one article for resectability. Okay. Then E will be like venous encasement more than 180 degrees. Okay.
Okay.
So with no stenosis, with stenosis will be B and C. D will be teardrop. Okay. Teardrop, you know, no? Like when vein is stenosed and it falls like a teardrop. Okay.
Yes.
And more than 180 degrees encasement, it is type E. So these are the types of classification of venous relationship. Fine. So yeah, now what do you think from the CT abdomen pelvis report, Rakesh? What do you think about this case?
A report, ma'am. Just I'll read it.
You can zoom it and read. Report is in next page, I feel, Samita.
Focal exophytic lesion involving head neck of pancreas causing cutoff of main pancreatic duct and distal extrapancreatic portion of CBD with moderate upstream pancreatic duct and biliary dilatation, likely primary neoplastic lesion of pancreas, and few portocaval, perigastroesophageal lymph nodes, query metastatic, bilateral simple cortical cyst, and mild prostatomegaly, small left-sided inguinal angina.
That's okay. So he has bilirubin of how much?
Bilirubin was 18, I think.
So what do you want to do? 18 was total. So 11 was direct. Okay. Tell.
So
In this
total
case, what?
bilirubin is 18.5 and some regional suspicious nodes are also there. So according to CAD's classification, it becomes borderline resectable with the type B, BRB. And we can plan for NACT as well. And
pancreas में वो
for in practice, we generally can operate the afferent also.
First, do you want to stent the duct? Jaundice is 11, na?
There is no cholangitis and we are planning afferent surgery, then ma'am, we can go ahead with experiment.
You think it is resectable, borderline resectable from the description in CT?
So the vascular relation with the vessels is not mentioned. Considering it to be normal, ma'am, then it is resectable, ma'am. But if we follow that CAD's classification, it will.
So show him this one, na? Pancreas.
Main pancreatic duct. No vascular involvement is noted. The lesion is abutting posterior wall of pylorus of stomach.
I mean, exam, do they give the scans also?
Yeah,
or
they do. They do give the scans. They do give the scans of the same patient who have examined.
and reports, or are we just supposed to see the scans only?
Only scans. They'll ask you scan. They'll ask you to read the scan.
Achha.
Okay.
This is resectable. Anatomically, it is resectable.
Okay. So resectable. So yeah, you have your own. I mean, protocols as per hospitals, like when to stent and when not to stent. So that's a matter of debate.
Ma'am, one more question. I think the newer classification of borderline resectable also considered the biochemical and the clinical aspect, no, ma'am?
Condition.
Yeah.
Yes. Condition.
Yeah.
BC.
So we.
Yeah.
According to that, it will be borderline B.
I think this patient's albumin was also less, if I'm not mistaken.
Albumin, yes, 2.3.
2.3. So you would like to improve the patient's nutrition status, first
Yes.
of all.
Yes.
Yeah. You won't want to buy time. So
you have to
it's
stand.
better to
Stent and
it's better to stent.
yes.
So, okay, you have to see all the performance status, lab reports, and imaging to say whether you have to stent first or okay. Now you tell me what are indications for NACT? Oh, first, what are indications for biopsy in a pancreatic lesion?
Biopsy, ma'am, if we are having some confusion about the differentials, like some
For
causes which
NACT is also
cannot
one of the indication for biopsy or FNAC.
Yes.
some differentials
NACT.
which
If you are planning for NACT, yes.
extensive surgery like lymphoma can be there and pancreatitis can be there. If we are having some confusion, second, for planning any neoadjuvant treatment, we can need biopsy. We have to do
And
biopsy.
metastatic setting.
If see, there are 3 C's for biopsy. What is that?
C, chemotherapy, and
Yes. Chemotherapy means NACT. Yes.
then condition of patient not fit for like surgery,
Yes. Condition. Then
Coagulopathy.
coagulopathy,
coagulopathy. Okay. Cholangitis. Okay. So do a stenting. Okay. Take biopsy. Wait. Okay. So that is the thing. Okay. This is you have to decompress and then take a biopsy. If you suspect metastasis. Okay.
Any bilirubin cutoff, ma'am? Usually they say if the bilirubin is more than 15. So
Generally, see, it is again matter of debate. One thing is that we do prefer not to. It depends on site of lesion also. Okay.
not
So if it is liver, okay, if you want to plan for liver resections, it should be ideally less than 3. Okay.
yes.
So and if you are planning for pancreatic resections, we take cutoff of 15, not necessarily, but definitely never above 20. Okay. So it depends. depends on who is operating, what is their experience. But I do always feel, I have seen many Whipples, okay, but I always feel that the morbidity due to stent is very less compared to not improving a patient and operating on very high level of jaundice. They don't recover well. Post-operative period will be very, they don't recover well. There'll be very long recovery time. So it's better to stabilize, I feel, rather than, it's my feeling, but it depends. Yeah, there is no cutoff as such. Okay.
Even some articles quote, ma'am, that 90-day mortality is more if it is.
Yeah, it is more, and we have seen here. I've seen, I think, more than from my PG period, more than 20-30 Whipples I've seen. But whatever I've seen, like they have, sometimes it hurts ego of a surgeon to, okay, I can operate at this level of jaundice also, and I can send home patient without any, uneventfully it will be there. But they don't recover generally. Okay, so think about patient, think what is his general condition, think about lab parameters. Whipples is such a surgery that if you mess up with small things, they will show you the real colors in post-op period. So now we have a Whipples patient. So because I was telling sir that third, fourth post-op day he removed the Ryle's tube. Okay. So generally these patients will have delayed gastric empty.
Yes, ma'am.
So she kept on vomiting, and after one day of removal of Ryle's tube, I told her we'll reinsert Ryle's tube, and it was like 2 liters, 2.5 liters, because they'll not have gastric empty. So small things matter. So don't be in a hurry when you operate. Okay, so be slow in Whipples. Don't bother about anesthetics commenting that how long will you take. So your first case will be, whenever you do your first case, so be careful. Just think about the patient. Patient should not come back again. In spite of best things in Whipples, their mortality rate is very high. So it depends on where the lesion is, but still, so their 5-year survival is very less. So take care about the small things, so that you don't cause mortality in post-op period itself.
And ma'am, that's like every time we do stenting, it's not compulsory. Like we give chemo also. We can wait 2-3 weeks and operate like that. Can we do?
Yeah.
Once you stent, okay, that's what I was asking. What type of stents you use?
For shorter time, we can use plastic stents. Otherwise, metallic stents are preferred. Covered metallic stents.
What is the length of the stent that we use?
6 centimeter.
Okay. So yeah. There are short stents, long stents, okay, self-expanding metal stents. So what did you say, plastic stents for?
If for short term, we are planning surgery after normalization of bilirubin 2-3 weeks.
Yes. And when you are seeing it on the palliative basis, so
then
you put in a
covered metallic stent.
So what are the problems when you put in a stent? Like, why are they so afraid, like, to operate on a patient post-stenting?
Post-stenting will be there. There will be loco-regional inflammation, scarring, and wound complications will be high.
Okay. So more likely causes of injury. Okay. Yes. When you are operating in that narrow space, no? So more likely causes of injury. So what about post-stenting? How much time will you wait?
Post-stenting, ma'am, minimum 3 weeks, 2 to 3 weeks, I think, 3 to 4 weeks.
Yeah. Previously, they used to tell 3 weeks, but some people do operate earlier, also within 1 week or after 3 weeks. Okay. That is the scenario. So then, okay, what are the indications for NSCT?
And that we discussed, ma'am.
Yeah, borderline you told. Then
borderline, cholangitis condition, delayed surgery. If some delay is expected, like patient is being referred or whatever cause, then no.
Oh, fine. So what NSCT you want to give and how many cycles?
depends upon the performance status and disease status. If it is good performance status and disease is early, AFP is less, like less than 185, we can give FOLFIRINOX and FOLFIRINOX according to the PRODIGE 4 trial. And if the GC is like moderate, somewhere in between, we can plan gemcitabine with nab-paclitaxel or gemcitabine with the capecitabine. And if it is like towards
So tell me two trial, okay, where in neoadjuvant in borderline resectable, neoadjuvant in resectable.
neoadjuvant in borderline resectable, ma'am. Neoadjuvant, ma'am, that our Norpec and PRODIGE 48 and Isopec 5F. And Panda trial, PRODIGE 45.
Priopanc Alliance.
Priopanc, yes. And Alliance trial.
Priopanc. So, what were the drugs used? In SPAC3, what is SPAC3, SPAC4, SPAC5?
SPAC3 was ma'am gemcitabine and SPAC4 was gemcitabine with capecitabine. And 5. Sorry, ma'am.
No, 5. 10.
5 was in neoadjuvant setting. I'm not exactly remembering, but I think something related with gemcitabine only. Gemcitabine with
दिव्यांग चला गया क्या?
Hello.
In neoadjuvant, I think ma'am gemcitabine and capecitabine in neoadjuvant. I'm not remembering it exactly. I'm just guessing.
So 5-fluorouracil and gemcitabine, and 5 compared both.
Okay.
I'm not.
SPAC4, there was a 4 arm, ma'am.
4 compared, ma'am. 4 compared both.
4
4
arm.
compared both. Yeah.
Yes.
SPAC3 and SPAC5.
Yes.
Yes.
Yeah. So, any role of neoadjuvant chemoradiotherapy?
As such, ma'am, many trials have been attempted, but yes, ma'am, trials are there. Priopanc, I think they tried both.
Panda.
And this Panda trial also, PRODIGE 44. They said RT addition is not adding much. It is more toxic. The outcomes are not much altered by adding RT.
But they have compared
what are indications
with
for adjuvant chemotherapy?
Adjuvant we give in all cases.
Yes, we give in all. Okay. What are the drugs for adjuvant chemotherapy?
It will depend upon the general condition.
Yeah. So if general condition is bad,
then gemcitabine alone. If it is moderate, gemcitabine with capecitabine or gemcitabine with nab-paclitaxel. If it is good, disease was early and C19-9 was less, FOLFIRINOX we can.
Yes. So any role of adjuvant chemoradiation?
If margin is close or positive, margin positive we can give.
Okay.
Otherwise there is no role.
Okay. So now you tell me what is the surgical management? What is prehabilitation? What do you want to improve in prehabilitation? I'm not going into the details of all the trials and disease-free survival, overall survival. You read it up, okay? It's more of theoretical.
Ma'am, for this prehabilitation, is there any trial, ma'am?
So, to prehabilitate, ma'am, as this patient is non-diabetic, so we will first see the glycemic control, and we will start the. Yes, ma'am.
For prehabilitation, ma'am, is there any trial to decide what the level of albumin should be there? Is there any evidence?
Generally, more than 3.5 they prefer. If it is good, more
yeah, they prefer. I'm not aware of any trial, ma'am, but they prefer about 3.5.
In fact, sir asked me. I was searching, but I didn't get authentic trial. I also
the guidelines are there, no? that ISOPEN का guidelines for nutrition उसमें लिखा है.
Okay.
So yeah, tell me.
So ma'am, we will control the blood sugar, then we will start incentive spirometry, and if there is any cardiac issue, we will optimize that also, and
Okay.
we will explain the patient about the procedure, related complications and all.
Yeah. Then what you will tell the patient about the surgical things.
Yes.
Okay.
Yes, ma'am.
So now you tell me steps of surgery. What do you
So
want to do?
first, we can do staging left if the disease is locally advanced or CA99 is very high or it is distal tumor like body or tail tumor. Then staging left. If there are no lesions permitting the definitive, prohibiting the definitive surgery, we will plan for the definitive surgery and go ahead. We will do the resection
What is the incision you want to give?
in rooftop incision, ma'am, bilateral subcostal.
It has got any name?
Chevron incision.
Chevron. Bucket handle, chevron.
Okay. So next, what do you want to see? Opened abdomen.
And then if I've done staging left, then it's okay. Then if I have not, then I will see the peritoneal deposits, status of like any omental implants, liver lesions, and presence or absence of
You look
ascites.
for any metastatic lesions. Okay,
Yes.
no metastasis.
Then ma'am, like if there is bulky nodal disease or not, I can palpate in the porta as well as that region. If it is not there, then I will start with the resection part. First, I'll do the trial phase of that. So I will enter the lesser sac and see the status of
In
the.
this case, they are given suspicious para-aortic lymph node. What do you want to do? In CT, they gave no.
Yes, ma'am.
Cauterization and frozen section.
So ma'am, suspicious para-aortic node are there. So we can remove it along with the primary, ma'am.
Cauterization and frozen section, ma'am.
Frozen.
Yeah.
16B lymph node, ma'am, frozen section.
Yeah, it has role only for prognostication, like it is not going to improve OS or something, but it
So does your surgical plan differ with 16B positivity?
Yeah, it considered as a metastatic, ma'am. There is no advantage to
You can
do
take
for
a bypass, strip a bypass and come.
Yes.
Okay, you will not do a definitive surgery. They do bad. Okay, 16B is positive, right? So you do a frozen. Okay. 16B. 16B2. Exactly. Yeah. Then you have looked for metastasis, no metastasis. Then what is your first step?
Then we will do the cattle brass extended cauterization, and we'll check the tunnel of love through the lesser sac. If there is no issue as such issue, then we will proceed with the resection part. We'll do the portal dissection, then divide the stomach, divide the pancreas over the tunnel, and then do the
What are your limitation factors for resection?
limitation factors.
Or
Criteria for unresectability, ma'am.
No. It is resectable, but operability. Resectability only, not operability. Something you will see means in vasculature.
GDA.
We don't do, madam.
GDA.
Madam, we don't do this artery first approach triangle surgery to see the artery first before commenting on the
Depends on the stage, like locally advanced uncinate process ka mass hai.
If it is an uncinate process, that SMA first approach and all are followed. But generally, I don't know. I have not seen much people doing SMA first approach. Okay, so unless it is an uncinate process, so where you have to identify the vessels and all. So your limitation factors for resection, you identify GDA, no? If there is any.
Yes, ma'am.
You have got a GDS term or it is threatened, okay?
Yes.
And you will see whether posterior SMA margin, that is posterior margin. Okay.
Posterior celiac, any tumor abutting or like it will be seen imaging, but then intra of if there is extension.
Intraocular access. They are most common limitation factors for resection. Okay.
Yes.
Apart from this, okay, you did all PJ, TJ, HJ, all these things are okay. Fine. What will you see intra to assess the fistula risk score?
So, ma'am, we will see the texture of the gland, and then pathology we already pathology we don't know as we have not done biopsy, but then site of lesion we can see. Previous pancreatitis was not there or not. Then diameter of the duct and blood loss.
Intraoperative blood loss. Can you tell the fistula risk score?
Yes. So it has four that components. First is consistency of the gland. It is firm or soft. If it is firm, score will be 0. It is soft, then score will be 2. Then second will be the pathology. So if it is something related to head of pancreas, then score will be 0. If it is related to ampulla or periampullary, then the score, or duodenal, the score will be 1. Then the diameter will be divided. It is 5 mm or more, then 4, 3, 2, 1 or less. Score will be 0, 1, 2, 3, 4. Then we will see the blood loss. Is it less than 400, 400 to 700, 700 to 1000, more than 1000 ml, and score will be 0, 1, 2, 3. So score can vary.
So what's your assessment based on this?
Score can vary from 0 to 10, ma'am. Based on that, we have risk groups like low, intermediate, and high. High, if it is high score, like score is 9 or 10, then the risk will be more than 20%.
Okay. So it's about fistula risk score. So what are the steps? That PJ or PG had made.
Sorry, ma'am, your voice is not clear.
Was there any difference between doing pancreatico-gastrostomy versus pancreatico-jejunostomy?
Ma'am, practically speaking, there is not much difference, but then physiologically it can alter the milieu of the stomach, pancreatic secretions being alkaline in nature. Otherwise, there are not much difference.
Basic leak rates and bleeding is more common.
Less in PGs, okay?
Yes.
So they are more in PGs, okay? Yes. But if it occurs with PG, they're dangerous, okay? Blowouts are more common. What is Heidelberg technique, Rakesh?
Heidelberg.
What are types anastomosis of PJ?
Types like it can be dunking or duct to mucosa.
What is the Heidelberg technique?
Blumgart is also one of the techniques.
Yes, Blumgart is used. Heidelberg, I am not. We generally do modified Blumgart or some Srikande technique here. I think that is in 4-layer we do now. That Srikande technique is known as Heidelberg technique.
Yeah, 4 sites, not 4 layers.
Yes.
Okay.
Yes.
Neuromuscular to capsule.
Yes. Yes.
But it is a combination of duct to mucosa and dunking can also be done.
Yes.
So what is the specialty of Heidelberg? Why I asked it is because bile leak was less. Post-operative pancreatic fistulas, bile leaks, and the post-operative hemorrhages.
Yes.
The mortality was less because of this Heidelberg technique.
Yes. Our sir also followed this, ma'am, and we max to max we have seen 2 cases of biochemical only. Otherwise, all are fine.
So the PJ or PG did not make any difference. Duct to mucosa or dunking did not make any difference. There's something called binding also. Okay.
Binding.
Binding technique. And there is the stent placement did not make any difference. Okay.
Yes.
On meta-analysis. Okay. There are some 8 meta-analysis which have studied about all this. Okay.
Dunking with a small ball, I have not seen ma'am any time. Like dunking using jejunum or something. Mostly
Dunking?
it is PG.
You
Mostly
have not seen dunking, yeah? Okay.
that small ball ka dunking I have not seen. Jejunum.
Okay. We do. Okay. So any difference with brain placement was not there. Okay.
Yes.
Any use of using octreotide?
In high risk patients, aceriotide can decrease
No,
the.
any use in long-term studies by using those things?
In high risk, as such, there are most of studies are saying there is no difference, but
No, as of now, nothing. Okay.
Yes.
So they have used according to their convenience. Some believe, some say it's useless. Okay.
Yes.
So what suture material will you use for PJ and what you will use for HJ?
We here use one PDS 4050.
Yeah.
50 for PJ and 40 or 30 for HJ, depending on the duct status.
Okay. So you are supposed to use non-absorbable suture for HJ. Okay.
Yes.
And you should handle it gently. Okay. There should not be any obstruction. You should be doubly sure there should not be obstruction. Some people place stent, so they use infant feeding tube to place stent. Okay.
Yes.
And you should do a proper approximation and confirm that there is a good vascularity. Okay. For doing things. Okay. And tell me some approaches. He told SMA first approach. What are the approaches in that?
SMA first approach, ma'am, can be anterior, posterior, superior, mesenteric side, or left or right, depending upon the pathology and epicenter of the.
Supracolic, right medial approach. Okay. Then left lateral, posterior approach, superior approach, transverse mesocolic approach. Okay, these are the approaches. So most commonly when it is in the uncinate process or close. Nerves के बारे में कुछ बताओ. So when will be the where more injury to the nerves might occur when you go?
Uncinate process, ma'am, when we will dissect.
No, when you go to medial to the vasculature or lateral to the vasculature?
Medial, ma'am.
Right medial approach, ma'am.
Right. We generally dissect lateral to the vasculature SMA, medial to SMA we avoid.
So where are the neurovascular bundles more there?
They say they are all around, but we have to protect at least one side of that plexus.
Yes. So you will always resect medial to the vasculature. You will try to be medial. So never go lateral. Okay. So what is mesopancreas?
Mesopancreas is the fold behind the pancreas, in between the SMA and head and.
It's an embryological plane containing
nerve, lymphatics, and fat.
It's a fibrofatty tissue containing neurovascular bundle with lymphatics.
Yes.
Okay. What is the triangle operation?
Triangle operation.
What is divestment?
Divestment from the artery, we follow that plane then.
Yeah, you go in the subadventitial plane.
Yes. So when we generally discuss on right side of artery, SMA. 1
second,
Okay.
Madam left.
We generally dissect on right side, then it will be lateral. Ma'am was saying medial. I think so.
एक मैडम से एक क्वेश्चन पूछने का था. When you just we clamp the GD है ना, तो aberrant और replace right hepatic के लिए देखते हैं. Anyone of got मतलब कुछ मिला क्या? If there is aberrant or replace right hepatic artery, how do you proceed? मतलब कुछ experience है क्या? किसी ने देखा है क्या?
मतलब generally we follow. We will apply bulldog and we'll see the pulsation of.
If there is aberrant or replace right hepatic artery, so how do you proceed? Whether you commit or not?
No, we will not commit. We will try to preserve it generally. But then apple by procedure wala.
Apple by procedure,
but still Appleby is more towards that अपना hepatic artery and
common hepatic artery.
yeah.
But वो recent guidelines से निकाल दिया है the resectability criteria के ऊपर से. It was there on previous guideline.
Hepatic artery वाला.
The Apple's technique. Aberrant vascular anomalies.
Okay. हाँ मतलब उसमें अपने को प्रिजर्व करना ही है. Replaced SMA, CHA और right hepatic, तो we have to preserve. If there are nodes, then we can abandon the procedure line.
तुम लोग मतलब प्री ऑपरेट
मतलब क्या रहता है मालूम है किसी को?
क्या रहता है?
ओरिंगोस्टोमी कुछ तो करते हैं ये, पता नहीं मेरे को भी, लेकिन वो बोल रहे थे.
क्या टर्म है? मेरे को पता नहीं क्या टर्म है.
ओरिंगोस्टोमी करके बोल रहा था.
ओरिंगोस्टोमी स्पेल कैसे करते हैं?
वरुण तो हमेशा ऐसे खतरा कुछ लेके आता है ना.
नहीं रे, वो मैं इधर हम ऑब्जर्वरशिप के लिए आए हैं तो इधर ऐसे आईसीयू में डिस्कस कर रहे थे वो लोग. पता नहीं अभी मैंने पूछा नहीं वहाँ से.
कहाँ पे गया है ऑब्जर्वेशन में?
अट्रैक्ट टाटा में.
भंडारी सर कर रहे थे. कौन? विवेक चौधरी सर?
नहीं उधर टाटा में कर रहे थे रेसिडेंट उनके.
ठीक है.
ओरिंगोस्टोमी
पता नहीं यार ये तो.
मेरिंगोटॉमी ENT का जैसे आ रहा है मेरिंगोटॉमी. टिम्पैनिक में
क्या मैडम बिजी हो गए क्या शायद?
पता नहीं, कॉल आया करेगा. Normally we skeletonize the GD and we apply the bulldog and we see if there is any aberrant or any vessel is there. If you found aberrant or replace right hepatic artery, whether to proceed or whether to, we don't have any experience. I haven't seen any case of like this.
Aberrant, if it is arising from the it's the only arterial vessel, and if it is arising from the right hepatic, the right hepatic is a branch of the so then that time we need to reconstruct.
Okay.
We'll have to reconstruct and to go ahead. Okay. Because the whole right side of liver will lose its vasculature. So
okay.
So, yeah. So I was asking about divestment. What is the divestment operation?
Subadventitial plane में we will start dissection and we will proceed upwards.
Yeah. So suppose what is this criteria of A, B, C we see in borderline resectable?
This is anatomy, biology, and condition of patient.
So biochemical is biological criteria is CA99. Above what?
500, ma'am. CA99 is above 500, and there is a lymphadenopathy either on the PET scan or biopsy. And third will be the ECOG score 2 or more than 2.
ECOG will be in condition age more than 8 years and ECOG more than 2.
Yeah, perfect.
And CA99, then there are two things are there. One say more than 1,000. Some other guidelines say more than 500.
Yeah. So suppose what is we already discussed Folferinov Prodigy 24.
Ma'am, role of lymphadenectomy, ma'am. Can you just highlight?
We need to clear the lymph nodes. We need to clear the lymph nodes in pancreas.
AJCC tells 12, ma'am, and then that our Anderson and...
You are asking number of lymph nodes.
No, see, he was asking about importance of lymphadenectomy.
You need to clear the lymphadenectomy. There is no way that you can spare lymphadenectomy in a pancreatic lesion. Okay. So what all lymph nodes you will clear?
We will clear, ma'am, around the porta.
So what is the most important prognostic factor in a pancreatic surgery?
Pancreatic surgery.
Because he asked, I am asking that question.
R0 resection.
R0, SMA ka margin.
R0 resection with posterior margin.
Yes.
Yeah, so R0 resection is what it matters. If you leave the lymph nodes, so what is the incidence of lymph nodes in as per stage?
Stage 4.
Stage like T3N1 will be stage 2. T3 or
Stage
N1.
4, ma'am.
No. Stage 2. T3 or N1. T4 or N2 will be stage 3. And N1 will be stage 2.
What will be the node positivity? Which stage you took? Stage 3.
N1 I think stage 2. I will check it again.
No, it differs with T side, T lesion, na?
T3 or N1. Yeah.
T3 N1 will be stage 3. Okay. So you need to clear the lymph nodes. What all lymph nodes you clear is retropancreatic, peripancreatic, pericholedochal, okay, periportal, retroportal, okay, right till your left gastric ligation on the other side. You will clear all the groups of lymph nodes, okay, along hepatoduodenal ligament, okay, common hepatic. All these lymph nodes need to be cleared, okay.
Ma'am, this
Because
SMA we do from right side, na? The SMA and uncinate process we generally approach from right side, na?
yes, that is for resection. I mean, that is for clearance of the pancreas. Okay,
So we will call it lateral or medial, ma'am. As you told, we keep ourselves medial, like I was.
So SMA has different approaches. No, one is infracholic, one is lateral. Okay.
Yes.
So one is from this side, right side. Okay.
Yes.
So one is supracholic. So it depends on where the lesion is. Is it in the head of pancreas? Is it in the uncinate process? Okay. Generally, we prefer either lateral or infracholic for the lesions in uncinate process.
Yes.
Okay. Yeah. So you need to clear the lymph nodes. Who asked? Yeah, whoever it is. So we need to clear the lymph nodes because the main aim is R0 resection. Okay. So and what else I was asking? Yeah. What is celiac axis resection? What is Appleby procedure?
So if CHA in locally advanced cases of body, ma'am, if the CHA is involved, we can resect it and leave as such. The blood flow to liver will come the SMA through the plexus around head and through the GDA. We will ligate proximal to GDA, the common hepatic, proper common hepatic.
What is triangular operation?
Triangle operation. Triangle operation. Is it related to bypass procedure?
No, it is related to this
SMA.
resection.
Removal of
It is the clearance between SMA and celiac axis.
Okay.
Yeah. It is like
Part of mesopancreas. Part of mesopancreas.
No.
No, it is entire mesopancreas clearance, but when it is the triangle is between the common hepatic, celiac axis, and the pancreas. Okay, so this is a triangle. So that's the area is clear. Okay, then what else? I think that is about surgical aspects mostly. I don't know if I've missed anything. Regarding chemo, what was the median overall survival in Prodige 24 with folfirinox?
And I'm not. It was around 40 to 50 months, I think.
54 months.
50 months.
Okay.
Yes.
And with gemcitabine, it was 35 only. Okay. So,
and one thing, ma'am, that we discussed borderline resectable ABC, na. So if nodes are there, it will be borderline B. So we should give NACT or not? What should we answer if nodes are there?
If nodes are there,
like paraortic nodes, like that, they ask.
paraortic nodes are considered metastatic.
Yeah. So regional enlarged nodes, we are going to resect otherwise.
No, if nodes are there, also you resect. Surgery is the prime thing if you can do it. The main concern in your borderline resectability is the vasculature. Okay, lesion, it is that too because you will not get a negative margin. Okay, So why all these are borderline resectability or locally advanced have come? Because the main determining factor as a prognostic factor in CA pancreas is that you should get a negative margin and R0 resection should be done. You just cannot shave the tumor off the vessels. So that is the main thing. So, okay. And what is the survival rate in head of pancreas and periampullary? Stage 1, stage 2, stage.
Survival, 5-year over survival for head of pancreas, ma'am. For localized disease, it is around 30%. For loco-regional, 15%.
And stage 4?
Stage 4, 6 months.
0. Okay. You cannot tell. Okay. What happens is you will do a very good surgery, but they'll not receive chemotherapy. So incomplete chemotherapy or not receiving full cycles of chemotherapy, that will decrease their overall survival rate because of lack of compliance or performance status. एक बार surgery हो गया तो they will be lost for follow-up. Okay. So and most of them are very anxious about receiving chemotherapy. They have their own thoughts about it. So that is thing. So yeah. Anything? What was the in neoadjuvant setting when you gave chemotherapy? What was the resectability rate, which are found to be resectable by giving neoadjuvant chemotherapy?
In borderline resectable, ma'am.
Yeah, borderline resectable, conversion to resectable.
30 to 40%.
30%, I think. 25 to no.
Then this one only won't come now. It was around 65 to 70%. Okay. So especially they were good with giving FOLFIRINOX. Okay.
Yes.
And R0 rate was also increased. It was around 80 to 85%. Okay. And overall survival was also prolonged. Okay. Around 20 months, I think 20 or 25 months. Okay. And radiation, if you want to give, like how much will you give radiation and where will you give? So are there any trials which compared neoadjuvant chemoradiation with versus chemotherapy alone?
PRODIS 44 is there, ma'am, in neoadjuvant setting for borderline resectable PENDA trial.
So any trial which has showed a positive, it was a what? Not negative trial, it was a positive trial. Any trial of giving radiation, which though there were many flaws with it, any trial of supporting radiation in neoadjuvant setting?
GI neoadjuvant, okay.
No, ma'am, neoadjuvant.
Adjuvant, it was GI study group. And
there was a neoadjuvant also, Japanese trial.
Okay.
The JESPAC was there.
Okay.
So that supported radiation. Okay. So they have shown survival improvement. I think increase in R0 result. Okay. Yeah. So and even Alliance trial has shown used radiation. Okay. What is vein resection without reconstruction? VROR.
If there are adequate collaterals, we can leave without reconstruction.
There is classification for vein involvement. You know?
You told ma'am.
Where you can do a patch repair, where you can do. Yeah, that is the types of involvement.
Yes.
There is classification for reconstruction also. So patch repair.
Type 1, type 2,
Okay.
type 3.
Yes.
Only segment we are removing or a part of vessel or patch reconstruction or some segment.
Clinic vein ligation is there or not? Then
clinic vein ligation won't come, but this is types of venous reconstruction. Okay. Yeah. So generally, why means we can leave without reconstruction also if the collaterals are formed. Okay.
Yes. Yes.
So this so all these things are to improve the operative criteria. So they wanted to operate. That's it. Okay. So then what is the role of multivisceral resections in pancreatectomies, pancreatic cholecystectomies?
Multivisceral as such, I have not studied, so I'm guessing it is not recommended. I have not
But
studied.
in distal pancreatectomy, ma'am, some kind
In distal,
we can do.
in talopancreas, we can do spleen alone.
Okay, which pancreas does bad? Distal or head or body?
Distal
Which pancreas
pancreas
does
is
bad?
bad. Distal
Distal, ma'am,
pancreas.
because they are diagnosed later.
Yeah. So
Yeah.
generally we can do, but their prognosis is very bad. Okay, they don't survive mostly. Okay, so then what is 5-year survival will be less than 12%. Median survival will be like around 21%. Okay,
Yes.
so what are the other lesions other than carcinomas in pancreas which you can get?
Cystic lesion or like neuroendocrine can be there, then cystic can be there. Lesions.
IPMN can be there. That is pen can be there.
Yes.
Okay.
Yes.
Yeah. So do you know any biomarker for pancreatic cancers which the startup people have studied?
Like SMAD4 and then these one. SMAD4.
There was one biomarker S100A2. They have studied about that. What is your idea about minimally invasive surgery in pancreas?
For distal pancreas, we can Leopard try is there, but for pancreatic duodenectomy, as such, no level 1 evidence is there. Leopard 2 study was done, but it was stopped prematurely.
Ma'am, there is a one study. Hello, ma'am. For the periampullary.
Okay.
वो है ना पलानी वैल्यू का स्टडी है ना पेरिएम्पुलरी के लिए लैब वर्सेस ओपन सेम ऑन्कोलॉजिकल आउटकम लैब एसोसिएटेड विद द डिक्रीज हॉस्पिटल स्टे
ये मतलब मॉर्बिडिटी का ही था मैं तो
मॉर्बिडिटी को रूटीन अपना
उसका क्या तो नाम था नाम याद नहीं आ रहा
नहीं वो उसका नाम नहीं पलानी एलिवेट ऑल स्टडी है वो आईसीटी
इसने पढ़ाया मैं चेक करता हूँ इसने पढ़ाया था दिव्यांग ने कुछ
दिव्यांग भाग ही गया उसको सब आता था FLR भी पूछ सकते हैं
FLR तो लीवर में
हेलो
यस मैम
Yeah, sorry, I was muted and I'm asking question. Okay, so what are the most common complications with Whipple surgery, and then we'll close.
Delayed gastric emptying is most common, ma'am.
What do you want to do for delayed gastric emptying?
Mostly wet and watch, ma'am.
Anything else?
Pylorus preserving surgery.
But not shown significance on studies. There is not.
Start late, okay? Depend on your FJ, okay?
We usually put NJ, ma'am.
Yeah, that. Anyways, you have to bypass that gastric outlet and then go. Okay. Then next, post-operative hemorrhage.
Post-operative hemorrhage, you will divide it early or late, like within 24 hours, more than 24 hours. Then intraluminal or extraluminal.
So you know about sentinel bleed, right?
Yes.
So if you have sentinel bleeds, you have to be very careful. What can you do?
We will see if it is from like the GJ side, we can control it endoscopically. Otherwise, we can embolize based on CT angiography.
Can do embolization. Very rarely, if it doesn't subside, re-exploration. But most of them will be Not successful. Okay.
Gone case.
Then anastomotic leak.
Anastomotic leak will depend on grade of leak. So
What is high output? What is low output?
high output is more than
500.
500 per day, ml per day.
Is it in pancreas? It is 500.
But small ball fistula, I think.
In pancreas, it is 200.
200, 200. Yeah.
So anything above 200 is a high output only.
High output,
But
yes.
you can wait and watch. Most of them will settle down with conservative management. Sometimes octreotide helps. Okay, keep your drains for a long time. Okay,
Yes.
they are your lifelines. Okay, so how do you suspect a pancreatic or jejunostomy leak?
Pancreatic jejunostomy.
Amylase.
Amylase, we will check the drain amylase and we'll compare it from the serum amylase.
So how much it should be?
More than 3 times,
Yes.
then we will suspect.
If how do you suspect HJ leak?
Bile in the drains.
Okay, fine. And GJ is very rare to leak, but it does sometimes. Okay.
Yes.
So suppose PJ is not settling.
PJ.
What can you do?
PJ leak is there, ma'am, ऐसा?
PJ leak है, settle नहीं हो रहा है. Conservative measurement.
Then we can
Anything to come?
re-explore and
Do what?
total pancreatectomy.
Can you do a PG?
Yes, we can do PG, ma'am, if it allows.
Yeah.
We can do PG.
Depending on the pancreatic status. Okay.
Total pancreatectomy is last option.
Yes.
Yeah. Generally, you should do PG. Okay, as first option.
Yes.
Then what else? Complications, wound infection, all that. Okay.
तो मैम पीजी किया है तो पीजे करना है क्या?
नहीं, PG.
Nah. It's not vice versa. If you have done a PG, you cannot do PG. It will leak and further.
In our setting
UPF
ऐसा
मैम।
मौका आया नहीं है कभी हमको पैनक्रियास को री एक्सप्लोर नहीं करना पड़ता है. एक ब्लीडिंग के कारण किया था बट वो पेशेंट फिर बचा नहीं था.
Yeah, one GD aneurysm हुआ था, मतलब aneurysm of splenic artery हुआ था मैम. One patient
Yeah.
died.
You can embolize it. You can put that head-shaped stents and all. Now, so many things happen.
Ma'am, post-operative pancreatic fistula. This,
Yeah, types of post-operative pancreatic fistula. Last.
sorry.
Grade
ABC,
Yeah,
ma'am.
great. Sorry, ABC. Great.
Yes. So C will be, they will need admission, they will be sick, they will be, can be in shock.
पूरा
sepsis,
organ dysfunction
They will
रहेगा.
need surgery. Okay,
Yeah.
B is some
But-
interventions. A is
A is
conservative.
biochemical leak. Yes, sir.
Biochemical. So just see that complete this one. Okay,
Yes, ma'am.
grading. That's it. No, anything else?
DG का grading also. Types.
Delayed gastric emptying का भी.
इसका भी ग्रेडिंग है.
ABC है उसका.
ABC. 7, 14, 21 days.
बाप रे.
Not able to tolerate.
NG requirement
And prokinetic.
and prokinetic use of
Reinsertion of riles or not able to tolerate solid foods.
हम लोग तो यूजुअली सब में ही एनजे डालते हैं इसलिए शायद प्रॉब्लम ही नहीं आती किसी को.
Depends on days na, when we remove.
It's duration with all these things what he told.
Ma'am,
बोलना भाई.
Tell there. We'll close after your question.
ERAS protocol in pancreas ma'am कुछ मतलब
ERAS
we don't follow the, like, it's there on the book.
Yeah, there is ERAS in pancreas.
Everywhere ERAS is
very unlikely to be followed.
Followed, yes ma'am. Like we have some hepatobiliary team ma'am. They start orally from the day 4 and soft diet from the day 5, but there are lots of complications immediate after discharge and all that.
That's what.
So, no.
Sometimes you should leave your ego and go with what is happening.
Generally, we start mostly 5-7 days, but we keep the NJ also for 2 weeks.
NG or feeding jejunostomy.
We keep it, but we start only.
हम लोग का एफजे अप्रॉक्स बंद हो गया है. हम लोग का एफजे अब बहुत ही कम डालते
Yeah,
हैं.
some people are not doing FJ. And Shankara also, one team does FJ, but one team doesn't do FJ. So here we do FJ. We want to sleep peacefully. So the patient has to have nutrition. They cannot afford CPN for long. So it's better we do FJ, otherwise NJ at least. So, but NJ is quite irritable. Patient will pull out right too. So they might pull out NJ also somewhere. Okay. Fine.
Okay,
We'll
ma'am.
call it a day.
Thank
Yes,
you, ma'am.
ma'am.
Good night, ma'am.
Sir का trial is
Okay,
not trial.
good night.
क्या?
Not
Sorry?
That Palani Velu sir का trial minimum invasive is plot trial. Plot.
Plot trial, okay. It's for periampullary, not head of the pancreas. It's for the periampullary. Inclusion criteria.
Leopard is for distal pancreas.
Leopard is for distal
And Leopard 2 is for pancreatic.
pancreas. But Leopard 2 बंद कर दिया ना.
हाँ.
Because of.
If OJ comes, they will ask you physiology basics. Okay?
Okay, ma'am.
Nothing more than that. Okay? So OJ
बिलिन
is
में ही
one
उड़ा
case
देंगे
that
वो.
they will
Ma'am, we
be-
conducted the examination here, ma'am, during my second year. We put as a OJ as a case. तो एग्जामिनर ने मतलब इन्वेस्टिगेशन पे वाइंड अप कर दिया. उन्होंने ट्रायल पे गए ही नहीं. मैक्सिमम
No,
अप टू द
OJ they will
रिसेप्टिबिलिटी.
not go. They will ask you exactly same questions. What is enterohepatic biliary circulation? What is jaundice? Why this one? There only the examination ends. Nobody expects you to know Whipple's का कौन सा क्या करना है. All this. You can do it later, but if you reach that level, that means
You are
that
passed.
stage you are passed.
That's right.
Okay.
Okay.
Okay then. Huh?
Good night, ma'am.
Bye.
Good night,
Good
ma'am.
night.
Thank you.
Good night.
Thank you,
Bye.
ma'am.